Good morning, everybody, and welcome. My name is Jean-Pierre Chanoine, and I'm a pediatric endocrinologist in Vancouver, Canada. I'm also the president of Global Pediatric Endocrinology and Diabetes, which is a non-profit organization founded by Dr. Zev Orberg, and that I registered as an NGO and a charitable organization in Canada in 2010. GPED aims at improving the care of children with endocrine disorders or with diabetes living in low and middle income countries through public advocacy, education of local health professionals, support of families and patients, clinical collaboration, and development of translational clinical research. We have more than 300 members. Registration is free. One of the main activities of GPED is education and information through newsletters, webinars, and booklets. GPED is one of the 13 regional societies in pediatric endocrinology around the globe, and we are united under the International Consortium of Pediatric Endocrinology, or ICPE. We did not have an annual meeting until now, and with this first edition that you are attending, this goal is now achieved. Yes, this year we have developed our first global GPED meeting. It is a virtual meeting, and it was made possible by the hard work of our organizing committee, Dr. Diane Stafford from the US and Agustini Utari from Indonesia, who are also GPED vice presidents. And from west to east, Dr. Paola Duran from Colombia, Agnès Linglar from France, Joël Di Passanema from Botswana, Abed Abulibde from Palestine, and Ganesh Jevalikar from India. Our management team includes Arnetta, Anissa, and Miosha, and they are medical students from Indonesia and Canada. They were instrumental in organizing all aspects of this meeting. And Dr. Sorolan Rera, fellow in pediatric endocrinology in Quebec, who will gather questions from the audience in the chat. The strong point of our meeting is the focus on addressing the needs of colleagues working in resource-limited settings. We will see that the vast majority of the lectures reflect this objective, and this makes this GPED meeting different from other conferences. Our goal is to offer cutting-edge research, lectures, and promote global networking with peers and professional growth. For this first conference, as of October 25th, we had 841 participants from 77 countries. You will listen to presentations from 31 speakers from 5 continents, 6 oral presentations, and 39 posters were accepted. For this first edition, it is an annual meeting, and therefore we aim at having one every year, but I guess we have to start by naming it an annual meeting on the first year. We are thankful to Aquitas Therapeutics,
This meeting is being recorded.
Company from Vancouver, that is our gold sponsors, and to Tolmar, our bronze sponsor. This has allowed us to keep the registration fee at a symbolic $15. The rationale for keeping a registration fee as little as it is was to avoid mass registration in case of a free meeting associated with poor attendance. Not attending a meeting for which you register is human, and there are many good reasons for that. But as organizers, we have a limited number of spots and wanted all interested colleagues to be able to register. However, you also need to know that all presentations are recorded and that after the meeting, all conferences will be available for free on our media, and you are very welcome to contact your colleagues, your friends, and let them know about this. Some practical information now. We are using a virtual platform from FieldLoop. You have received information on how to use this platform. Once you log in, you will be automatically muted and your video will be off. The most important tab on the left is the Sessions tab, where you can follow the program and see which presentation is being delivered live. To send a comment or a question by chat, please note that you need to exit the full screen of the presentation. The Lobby tab provides general information on the meeting, as well as the social media links of GPED. The Networking tab allows you to connect with any of the attendees presently online. The Speakers tab takes you to the information on each speaker, And the showcase tab is where you can visit all the posters, and this is going to be available during the second weekend of the meeting. We are happy to let you know that 2 awards will be given. One of the best oral presentation and one to the best poster. The oral presentation session takes place on Saturday, November 2nd from 9:15 to 10:15 GMT. And the posters will be available for viewing on Saturday, November 2nd and Sunday, November 3rd from 1 to 6 p.m. GMT. So this is during the whole duration of the meeting on Saturday and Sunday. The posters will be available for viewing on Saturday, November 2nd. And we have invited the presenter to be online at the poster for 1 hour in parallel to the oral session on Saturday, November 2nd from 9:15 to 10:15 GMT for networking. The email contact of the presenting author will be available on the poster. The poster and oral awards will be announced on November 3rd with the closing remarks. As mentioned, everything is new. The content, the format, the platform, the organization. Yes, this conference is a new experience for you, but also for us. Should you encounter any issue, please email us at gpedmeeting@gmail.com or send a private message to the GPED office in the networking part of the virtual platform. Our team of managers will read these emails regularly and answer your concern. At the end of the meeting, you will receive surveys. First, one very short survey at the end of each day and one at the end of the meeting, and these surveys are key. All those who answer the final survey will be automatically sent a certificate of attendance. Today is the D-Day. We are very excited and wish you a great meeting. We are looking forward to your active participation as well as to your comments that will influence the organization of future meetings. And without further ado, I will now give the microphone to Diane Stafford, who will introduce the first speakers in a few minutes. And all of us have sometimes to get a cup of coffee or a cup of tea prior to starting the meeting. And I thank you very much for attending this meeting.
Good morning, everyone. And as I want to echo JP's welcome to our first annual GPED meeting, and I hope that everyone will enjoy all of the things that we have to offer. I have the honor of opening our first plenary session today. My name is Dr. Diane Stafford, and I'm one of the vice presidents of GPED, and I'm a pediatric endocrinologist from Stanford University in California. And I am very pleased to introduce Dr. Ana Aceves Capri, who is a physician from Mexico who works for the World Health Organization, providing technical advice on projects related to the WHO model list of essentials in vitro diagnostics. And she will be speaking today on the role of bringing these essential diagnostic tests to resource-constrained settings. So please welcome Dr. Ana Aceves Capri.
Thank you very much, Diane. I hope everybody can hear me well. But before starting with my presentation and while I'll share the screen, okay, please.
We can, Anna. You're great.
Thank you. So as I was saying before sharing starting the presentation, I just would like to thank the organizing committee for this opportunity to share about the work that our team, medical devices and diagnostics, the WHO, what we are doing to improve access to essential in vitro diagnostics, but also to improve access to other type of diagnostic tools. So allow me to move. What is the problem? And I'm sure everybody here is well aware of the problem. 47% of the global population has little to no access to diagnostic tests. And these are the results of the Lancet Commission on Diagnostics. Back in 2021, they published this report called Transforming Access to Diagnostics. And what they did was actually to quantify the state of access to diagnostic tests for mainly 6 conditions: diabetes, hypertension, HIV, TB, hepatitis B, and syphilis. And here in these slides, you are actually seeing the results. And basically what they said is that there is an urgent need to prioritize diagnostic tools and services within the context of global health, but also within the context of ministries of health, and especially within the context of universal health coverage agenda. So as I was saying, less than 50% of the global population has access to the most basic diagnostic tests. And the gap is indeed most severe at the level of primary health care. So as per their research and their publication, the Lancet Commission stated that low visibility and prioritization of diagnostic tests is the fundamental cause for the current situation of poor test access. And this is not only for in vitro diagnostic tests, but also for other diagnostic tools, such as imaging, for example. So one of the problems they highlighted in the report is that diagnostic tests are not explicitly included or mentioned in proposals for universal health coverage, and are largely missing from national strategic plans for health. The necessary physical infrastructure is deficient in many facilities, and this as a result, weak testing services, and of course, when available, most of the testing services is of poor quality. In the same situation, management and procurement system, technical support, information technology, and supply chains and are widely insufficient. And in the same tone, quality and safety mechanisms or standards are scarce. And last but not least, workforce. The global workforce is actually not enough, so there is a global shortfall of workforce. They propose several recommendations to address this very, very important problem, and they suggested higher political prioritization of diagnostic tests in general as a key to improve the situation, the need for diagnostic tests to be an integral part of any universal health coverage programming or agenda. There is urgent need of changes in policy, in governance, finance, of course, in infrastructure, workforce, and quality and technology innovation. And they also talk about my main area of work at WHO, the WHO model list of essential in vitro diagnostic that most of the people knows as just EDL. So this EDL is according to the Lancet Commission, is a useful tool for prioritization of tests in resource-constrained settings and an opportunity for progress. And indeed, we at WHO, we also believe that the EDL can help countries, can help member states to improve the current situation of poor access to diagnostic. But what is the EDL? So the EDL is mainly a health policy document. And one of the characteristics of this EDL is that it's based on scientific evidence. So it is not a list of commercial branded products, but it's a list of categories of IVD tests that include recommendations on assay format, on the test purpose, specimen type, and the healthcare setting where this particular IVD test is recommended or where the experts believe it can have the greater impact. So far, WHO has published 4 editions of the EDL. The first one was launched in 2018, and the last one was published in October 2023. Right now, our team is working in reviewing the EDL4, and we are actually preparing for the 5th meeting of the Strategic Advisory Group of Experts on In Vitro Diagnostics, the SAGE-IVD, that is the body that work with us in reviewing and updating the EDL. But okay, regarding the scope of the EDL, currently it only focuses on in vitro diagnostics. There are talks about making the scope greater to include other type of diagnostic tools such as imaging, but so far it's only in vitro diagnostics. So as you can see to your right, there is a list of disease or group of diseases that so far are within the scope of the EDL. But in just to be clear about the EDL includes general tests, but also disease-specific tests for both non-communicable diseases and infectious diseases. So as I said before, there is no branded products, but categories, genetic categories of IVD tests. And mainly the list includes tests recommended for medical care, meaning tests that are usually used in the context of clinical laboratories. But the list also includes some tests for surveillance and that would be normally used in the context of public health labs. So the EDL is organized in 2 levels. And within these 2 levels, you can see here, the first level is listing tests recommended for use in community settings and health facilities without laboratories. So meaning any test that can be used outside of a clinical lab, you will find in the first level. In the second level, we have tests recommended for use in healthcare facilities that has clinical laboratories. So this would include any basic lab, maybe in a small hospital, or maybe advanced clinical labs in tertiary level hospitals, or maybe some national national laboratories for reference, for example. But all of these would be included in the second level. And within these two levels, we have subsections. So we have subsection A and subsection B in both levels. Section A deals with general tests that are arranged by discipline. For example, hemoglobin, platelets, bilirubins, and they would be arranged, for example, within hematology or clinical, clinical chemistry, the usual services that you would find in a clinical laboratory. And the disease-specific tests are organized, as the name says, by the disease that I showed you in the table. For example, we have tests that are mainly used within the context, for example, of diabetes mellitus or HIV or tuberculosis, malaria. Last year, the CHIBD decided to add a new section of cardiovascular health, for example. So you will have this organization within the two levels. And in the level 2, you would also have tests for blood screening tests, or in other words, those tests that are recommended for use in blood banks. From EDL 3 and also in EDL 4, you will find a subsection called Do Not Do Recommendations. And this section refers to a few test categories recommended for discontinuation based either on evidence of harm or lack of benefit. And this is an example of the actual table of the EDL. And this is an example of EDL 4 now on the review. And as you can see, this is the second level, subsection B, disease specific. And in this case, the example shows a test for diabetes. So we have, as I said, a generic name, glucose, which is the analyte, which is the test glucose. Below, you have glycolated hemoglobin. And then you have a test purpose as formulated by the CHIBD, the safe format, and the specimen type that goes in relation to the safe format. And when available, you will have links to WHO pre-qualified recommended products. And also, when available, you will have links to technical documents. Since this is a group of specialists in endocrine disorders and endocrinology, I just wanted to show you that we indeed have a section called endocrine disorders, and these are the analytes or the tests that currently are here to your left listed as essential in vitro diagnostic tests in EDL. Right now, the CHIBD is indeed reviewing an application for total testosterone immunoassay, and when they have the meeting in November, they will need to decide if this total testosterone test indeed goes to the EDL5. But well, more on the EDL recommended use. So the EDL, indeed, we advocate for its use to prioritize and select IVD tests at country level. And this EDL, we are encouraging countries to use it to support national EDLs. And for those countries that already have some type of national list, we are telling them, use the EDL that is based in evidence to update your list, because we are aware that some countries have lists, but maybe are old lists that are based on traditional procuring or buying context and not really support on scientific evidence. So we are advising all the countries to use the EDL to review any existing list. Also, very, very important, and I would say this is critical, that both the EDL and national EDLs can inform universal health coverage priority benefit packages. And this is what we are actually advocating strongly to the countries. Please consider the EDL when preparing those priority benefit packages in the contents of universal health coverage. Also, the EDL can help decision makers define the tests that should be available at different levels of their particular system. So as I said, we only have 2 levels, but countries and the policy makers and the technical committees in charge of developing national EDLs are the ones that would be selecting those tests in the EDL and then allocating to their respective, let's say, level of the system. Also, we believe that with the proper creation and implementation of national EDL, the patients, the population, then will have better and greater access to IVD tests. And a very important reminder that the list, the EDL, is not needs to be used in the context of the wider national references, clinical laboratory networks, for example. The list, the EDL, are the very important policy document developed by WHO. If not use it within the scope of integrated clinical laboratory testing, then not really impactful. So context matters, and each country is different. So what we are proposing to countries is to develop their national EDLs using the EDL, but they are free to choose what are going to develop. We are aware and we are supporting countries using the different approaches. We have countries that has decided to draft a national EDL only for primary health care. And that's fantastic. We have countries that choose to develop national EDLs for the entire the level within their own health systems. So it covers first level, second, third, and depending on the levels of their system. We have countries that have chosen to focus on in vitro diagnostics. We have countries that are also including other type of diagnostics, like imaging diagnostics and electrodiagnostics. So what we are trying to do is provide the tools, and countries then will use them as they better think it fits their needs and their context. But with proper implementation of the national EDLs, you, the health professionals, will be able to have the test that you need at the level that you need it. And on the other side, the patients will be able to access these tests when and where they need it. So this is a brief summary of current efforts for national EDLs, both implementation, developing and implementation efforts. India and Nigeria are currently working on implementation, and we were recently informed that actually India is working now on updating or a review of their national EDL that was published in 2019. It was actually the first national EDL based on the EDL. Nepal has also recently finalized its national EDL. Pakistan and Timor-Leste are now in the final development phase, and we are supporting these countries on the review of their national draft. Honduras has joined the effort and now is working in the early stages of development of their national EDL. And we're also aware of other countries, such as Kenya, Malawi, South Africa, Ethiopia, the Gambia, Zimbabwe, and Vietnam, and Indonesia also working on national EDLs, some of them already finalizing the national EDLs. And we're recently informed that Burkina Faso, Madagascar, and South Sudan are already finalized with the national EDL development, but we haven't been able to work directly with these countries. So our team is not only supporting the review of national EDLs, but also developing tools to support countries in these efforts. As you may be familiar now with the picture of this blue book, this is the technical report series, or what we call TRS, that include the actual table of the EDL. But this book in particular is very, very useful for those committees working on national EDLs, since it includes a summary of the evidence apprised by especially methodologies and a summary of the deliberations and the recommendations of the SAGE IVD. So it's very, very useful when the technical committee are considering every IVD test for their national EDL. And well, the electronic EDL, which is let's say a web-based application of the EDL. I like it a lot because it offers a different way to review the EDL. If you go to the PDF, you just see the table and you just turn pages. And if you go to the electronic EDL, you can actually use filters to select or to become aware of what tests are in the EDL, and you can use filters from the level of the EDL, for example, basic primary level, and also the level 2, or maybe by disease. For example, if you are only interested in HIV and TB, then you apply the filter, or you can even use by assay format or sample or a specimen type, so it's very much interactive, and you can export the results of your own search. If you want the entire list, then you just go and click on the export button and you get an Excel version of the entire list. So it's really, really useful. And another tool we developed back in 2029 is this green book. It's the guidance is the guidance document, as we call it. It's a book that has recommendations and guidance for countries on how to use the EDL to develop and to implement their own national EDLs. We will be reviewing and updating this book next year. After the EDL5 is published, we will be updating this book. But now it's still available in the 2021 version. And very important also to mention, the electronic EDL has technical specifications. And one of the issues relating technical specifications that I love the most is that it's really a pragmatic use. If you are working within a program in the ministry, or you are working within the laboratory, and you are responsible maybe to choose or to select some ability tests or to procure some products, the technical specifications are really useful, because you get you just go to the EDL and click on download, and then you get access to these technical specifications that you can use. They are generic, again, no commercial products on it, but you can still use it maybe to support a bidding process, or maybe just to compare with what you are receiving from the industry or from providers. Just to clarify, the technical specifications so far are only covering infectious diseases mainly, and it's hepatitis B, HIV, hepatitis C, I guess, syphilis, streptococcus, antigen. We are working slowly, but working in developing technical specifications for all the IVD categories, but so far it's these ones that I have described. But we are not working only on in vitro diagnostics. Our team, as the name says, medical devices and diagnostics, also work on other type of medical devices that are not in vitro diagnostics. And our team has developed the Priority Medical Devices book series, and our team has already created MEDEVIS, which is the electronic version of these Priority Medical Devices books. So MEDEVIS and electronic EDL complement each other. In electronic EDL, you will have the IVD category, like the test, but in MEDEVIS, you will find, for example, all the related laboratory equipment that you need to run those tests. And of course, you will have other diagnostic tools, such as imaging diagnostics, meaning you will have information on other type of, for example, imaging resonance or tomography or basic things like stethoscope. Everything is there. So also very useful and complementing the work of the EDL. Very important too, we work very close with our colleagues in the pre-qualification program. So WHO has this WHO pre-qualification program, and they have a group working on pre-qualification of in vitro diagnostics. And in this list that they produce, I mean, you will have actually commercial products or branded products. You can access to the latest products they have pre-qualified using here the hyperlink. But basically, just what I want to say about this is that we are working closely with them to try to align what we are working in the EDL with what they are working on the pre-qualification products. Very important to say that the scope we have in the EDL is larger than the current scope of the PQ programming. They have the scope of diseases that are currently eligible for submissions for pre-qualification is this. So no, only limiting to that. We have other diseases and also general tests. So some of our IVD categories won't be within their scope. And of course, they have very strict criteria regarding the eligibility principles, and well, you can see them. You can see them here. Sorry. And the EDL Secretariat, the EDL Secretariat and the EML Secretariat. EML is Essential Medicine List. We're also working with them, and the idea is to align the IVD test in the EDL with the medicines listed in the EML. Now we're working with them to try to identify those tests that require certain diagnostics tests. So what we are trying to achieve is that if they are listing some medicines that require some tests, we are then calling for applications to receive those submissions and then analyze the evidence. One of the challenges we have here is that some of the tests are for cancer diseases, and this is very expensive, but the important thing is that the dialogue is there, we are working, and the evidence needs to be assessed. And what we are doing now is, as I was saying, reviewing the EDL4, and now we have, it's about to finish. The last day of October, it's the last day to the public comments. So I would like to invite you to go to our website and click on this call for comments, where you will have access to all the EDL5 applications we received. We received 18 applications for this call for applications. And it's not only about the EDL5 applications, also about the EDL4 tests. So if you go to the EDL4, review the table, and maybe you think something needs to change, you can also provide your comment. And after October 31st, we will close the call, and you will need to wait to the next call for public comments. So I really would like to invite you to go to this website, to the WHO website, to this particular page, and just check it. Maybe it's you will be interested in submitting some comments before the end for public comments ends. And on the 25th of November, we will have the first day of the first meeting of the 5th meeting of the Strategic Advisory Group of Experts. And this meeting is a closed meeting, with the exception of the first day, where the EDL Secretariat hosts an open session for everybody, anybody to join and listen to the discussions, listen to the presentations, and also interact with the Strategic Advisory Group of Experts, the speakers, invited speakers, and with the Secretariat, because at the end of this open session, we will have a Q&A question. So we will have this open session in the form of a webinar, and you can register here. I will be sharing everything with the organizing committee, and the slides has hyperlinks, so you can just click and go and then register if you are interested in joining this webinar. And yeah, indeed, I think this is my latest slide. I hope I have done with the time properly, but I just would like to close by asking you to remember that in countries and settings where resources are scarce, the EDL indeed can help to identify and prioritize those IVD tests that should be available in each country. The EDL is a tool that helps decision makers within the Ministry of Health to develop, order, and implement national EDL according to each country's needs and priorities. And with proper implementation of national EDL, lab professionals and all healthcare providers could have the appropriate IVD tests available where and where needed. And most important, the population, the patients, their family will have hopefully increased access to IVD testings. And with this, I would like to end. A few links in the presentation for you and my email in case you want to reach me. And now I would like to just go back to Dr. Diane. This is all on my side. Thank you very much.
Thank you so much, Ana. That was really wonderful, and I think such an important part of working to provide care for our patients across the world. So, thank you so much for participating with us today. To invite everyone to join one of our 2 Meet the Expert sessions. You can do so by going back to the main page for the meeting and going to the. You enjoy the rest of the meeting. Thank you.
This meeting is being recorded.
Endocrine disorders. Over to you, Margaret.
Thank you. Thank you for the introduction. I'm just trying to share my screen. There we are. Okay. So we're going to talk today about early menarche. Can everybody hear me? I hope.
Yes, Margaret.
Good. So the question is whether we should treat this problem or how important it is for families. And I think we have to start off with talking about what is menarche and what does vaginal bleeding mean to a family. To define it, menarche is the first vaginal bleeding at the achievement of maturity of the hypothalamic pituitary ovarian axis in a girl. And it's usually accompanied by full feminization and linear growth, which is nearing adult height. I think that's very important because people sometimes confuse other vaginal bleeding. So other vaginal bleeding at different times is not menarche, and it doesn't have the same implications of the child being mature, although families assume that all vaginal bleeding means that the child is becoming to the end of the growth, and this can create major confusion for people. Strangely, most families assume that vaginal bleeding is normal, even though it may be at a very unusual age. So what is normal? Bleeding that's very, very early in the perinatal period, because the hypothalamic pituitary ovarian axis is active in the fetus and there's placental transfer of maternal estrogen. By term, as you know, there are very common to see babies with breast buds, hypertrophic labia majora, and an estrogenized hymen edge if one looks. The consequences of all this is that there's a vaginal estrogen withdrawal bleed. There may also be some galactorrhea. And then another normal variation in vaginal bleeding is a little bit of bleeding at the onset of puberty. This, for some reason, does not seem to be well recognised by many people at all. When the hypothalamic pituitary ovarian axis begins to become active in late childhood, there's a very small amount of estrogen which is produced at intervals, which families often consider to be regular every month, but it's not necessarily every month at all. It's just happening. And it's usually produced about 2 to 4 times, and then it disappears as the estrogen level rises and puberty progresses. It's very commonly misunderstood. It's not recognised, and as a result, there are huge numbers of unnecessary investigations of this completely normal phenomenon. If you look at it in a graphical manner, here's a typical feature. My daughter just turned 8. She had her first period last month. When you ask, she had a normal birth weight, no childhood illnesses, no family history of early puberty, and you find nothing in a prepubertal child to examination. And that's what I was saying. As the estrogen levels rise, there's a little bit of on-off, and if there's enough endometrium, when the levels of estrogen drop, there's a tiny bit of bleeding. As puberty progresses, the estrogen level rises, the bleeding stops, and then it reappears 2 to 3 years later as menstruation. So what's less normal and more concerning with vaginal bleeding? Early activation of the axis leads to central precocious puberty, or estrogen can come from another source, which can either be ovarian due to gonadotrophin-independent precocious puberty, or less commonly, exogenous estrogen. When estrogen is present, there are other features when the estrogen is present for a prolonged period. So the possible causes of precocious puberty in any girl can be central due to some midline defect or hydrocephalus which the child was born with, due to the onset of a midline tumour precipitating abnormalities of the HPO axis, after surgery, head trauma, or sometimes with neurofibromatosis without obvious tumour, although it is usually reported with a tumour. It may be peripheral from an ovarian cyst or tumour, or with McCune-Albright syndrome with a GNAS mutation within the ovary. And there are other causes you might have to remember, including severe hypothyroidism, administered estrogen creams and gels, particularly these days with women using gels and creams on their skin, and possibility of lavender oil contributing. The presentation of precocious puberty is usually with breast development, which can be unilateral or bilateral, with vaginal bleeding, and with or without other pubertal changes with the growth spurt. Your assessment should include height and weight. Very particularly, I would suggest breast texture should be looked at very carefully and felt, because it will tell you whether the estrogen is active or not. You need to think about the bleeding in relation to the stage of puberty to see whether they are appropriate or not. You check for the obvious hypothyroidism or cafe au lait marks. And then you undertake the diagnostic test of gonadotropins, estrogen, thyroid function, the beta-HCG if appropriate, and any other tests that you think appropriate, including pituitary function and a bone age. Pelvic ultrasound may be helpful, and an MRI, which may need to be repeated frequently. We'll talk about that. So how do we differentiate these problems? The breast development in infancy, as I said, can be normal between birth and 6 months, which can be due to maternal estrogen. And then it's even more common between 6 and 18 months, where it's usually isolated and self-limiting. And this has to be differentiated from progressive puberty, either central, peripheral, or due to other features. The importance of your assessment is in how you take a history. Is it a very short history, or has this problem been going on for a long time? When you examine the patient, you need to know whether there is also sign of generalized puberty with pubic hair, whether there's an abdominal mass, whether there's some sort of visual problem that might tell you about a midline lesion, or cafe au lait marks to suggest neurofibromatosis or McCune-Albright syndrome. And of course, you will not omit the escalating centiles on a growth chart. And you need to be very careful to try and find any source of excessive growth, such as comparing the child to other children in the family. In general, if precocious puberty occurs in a girl over the age of 6 to 7 years at the first sign of breast development, it's much less likely to have an organic cause than in a boy of the same age who has early puberty. But you should beware of the excess signs, such as the cafe au lait marks or visual changes, or very rapid and very progressive changes. We should know when treating central precocious puberty, the GnRH agonist will effectively suppress the puberty, but it will not alter the final height at all if the child is over the age of 7 or so at the onset of puberty. And I think giving parents a false idea that you're going to suddenly make their daughter 10 centimetres taller by switching off puberty in a 7 to 8 year old is really very inappropriate. You should expect a vaginal withdrawal bleed at the end of the first month of GnRH agonist treatment, and it indicates the loss of estrogen. And unless you tell the parents that this is going to happen, they take fright. Having said that, tumours are associated with central precocious puberty, and they are usually glioma, germ cell tumour, or hamartoma. Those gliomas that are midline across the optic chiasm that produce central precocious puberty, the ones that are associated with NF1 have a lower mortality than those that do not have that association. Germ cell tumours are common and are roughly 5% of all intracranial neoplasms in children with a peak incidence at puberty. They are more common in males, but they certainly occur in females. They're usually in the midline, and up to 50% have an associated lesion in the pineal region or in the third ventricle. The important point about these tumours is they can be extremely small at first, and they have to be looked at recurrently with MRIs anything up to 6 or 7 years from the first start of the precocious puberty. You cannot get away with thinking that a single negative MRI means that there's no tumour. And hamartomas, whilst fairly uncommon, can present with a mass effect, hypopituitarism, or precocious puberty via GnRH stimulation. And you can see there a picture at the bottom of a totally circular lesion in the hypothalamus, which is typical for a hamartoma. Then we need to think whether this isn't central precocious puberty at all. So let's look at a couple of cases here. Here's a 2-year-old child who's had a 3-week history of breast development seen by the family. When you look at the gonadotropins, they are absolutely zero, with an enormous level of estrogen at 4,750 picomole per litre. Androgens are all low. So this is a sudden onset of very, very high estrogen. The likelihood in this case is that it will be either an ovarian cyst or tumour. And you can see here in a Caucasian child, that's the child that we're talking about, who has very dark nipple pigmentation. And that is a giveaway in a light-skinned child that there is an enormous amount of estrogen because it actually looks like the breast of a pregnant woman. Not so easy to pick when there's darker skin pigmentation. If you compare this with the 5-year-old child who has short stature, slow growth, and breast development. Now, those look as if they're wrong, don't they? Because breast development usually occurs with rapid growth, so you immediately think of hypothyroidism. There is the thyroxine that is undetectable with a very high TSH, and you get the pseudo-precocity due to a crossover of TSH and FSH at the hypothalamic receptor, and it's associated with big ovarian cysts, which may be so large that they undergo torsion. So how should we manage these problems? If it's central precocious puberty, you can switch it off with GnRH agonist. If it's peripheral, you can remove the lesion, hope that things get better, but there might be secondary central stimulation, and you may end up anyway with GnRH agonist. You can block estrogen production with tamoxifen or letrozole. And obviously, if there's hypothyroidism, you can treat it. And if there's exogenous cause, remove it. So we need to think, why should we intervene? When, in whom, and what intervention should we use? So if we have gonadotropin-independent precocious puberty associated with McCune-Albright syndrome, you can see the typical cafe au lait spot here in a 4-year-old child following the lines of Blaschko around the chest wall. The treatment clearly is not of GnRH agonist because there is no stimulation of gonadotropins. Here, we need to use the possibility of an aromatase inhibitor, tamoxifen to block the effect of estrogen at the growth plate, to try and get a little bit of extra height. And there's not very much evidence, I'm afraid, for good outcome. That should be GnRH agonist, I'm sorry. That can be necessary if you get secondary central stimulation. However, this has long-term effects. For girls who have McCune-Albright syndrome, you might expect ongoing menstrual irregularity with this variation in estrogen production. They may have very, very heavy and frequent periods. And in future, because there's an enormous estrogen drive, the girls often, as adults, have severe fertility difficulties. So, if we look at when we should intervene, should it be immediate? The immediate action is required when there is recurrent bleeding with rapidly advancing puberty. Sometimes you may answer to parental anxiety, but that's probably better treated by talking to the parents about what to expect and to allay that anxiety. And perhaps if there's a very rapid advance of bone age that you've been able to demonstrate, clearly you may need to intervene. What treatment would you use? GnRH agonist is very valuable for central precocious puberty, and it delays bone age advance. It effectively switches off puberty, and it's used every 3 to 6 months, so it's not too arduous for the child or family. However, it's very expensive, it's not particularly comfortable, and it's possible if the powder is not properly mixed with the liquid, it can produce sterile abscesses. And you can see in the picture there that that's a typical sterile abscess, very painful and can be recurrent. They can usually be avoided by very careful mixing of the two components of the GnRH agonist. If the money is not available, but you need to switch off puberty, it is usually possible to do it alternatively with a progestogen, which is cheap and very simple. You can use around 20 to 30 milligram per day of medroxyprogesterone acetate. It's not as effective as GnRH agonist, and it doesn't hold the bone age in the same way. It's possible to use the 3-monthly Depo-Provera injections, which would not be used in an older person because they are so strong that they switch off the whole axis. But in a young child, the axis is not meant to be switched on anyway, and so you can do very well with treatment. With a lot of progestogen, you often have a moody child. And obviously, if there's a tumour, it may need to be dealt with on its merits. So if we switch to what is normal menarche, the onset of puberty is normal at the age of 8 years or more in a girl, and it usually takes 2.5 to 3 years from the beginning of puberty to menarche between age 10.5 to 13 years. That would be fairly average. You should consider the possibility of needing investigation for girls with precocious puberty starting less than 8 years. Now we're going to talk about just early menarche, which can be familial or functional. Menarche at the age of less than 6 is extremely unlikely to be normal, and it's extremely unlikely to be acceptable to the family, and it needs full investigation and suppression of puberty with a GnRH agonist if it's central. Menarche between the ages of 6 and 8 years is much more likely to be either familial, perhaps due to an MKRN3 mutation or some other mutations that are less common but associated with familial early puberty, or it can just be functional. This needs full investigation, again, probably with GnRH agonist, more for social and emotional reasons than anything else, because the height outcome in these girls is likely to be normal whether you intervene or whether you do not. And menarche over the age of 8 is probably within normal limits, but it certainly still needs investigation because you don't want to miss something like a tumour. There's some argument that perhaps you may not need an MRI, but you have to make that decision yourself, and it should be on the background of how quickly the progress through puberty has been, whether this is very rapid. And if the history is short, you should consider an MRI. So your decision is made based on chronologic age at presentation, the need or wish for height preservation, and those features. What will treatment do? It'll certainly cause breast regression. It won't cause the breasts to go away, but it will cause them to regress and become soft. And again, I would strongly advise that you look at the breast texture, you feel the breast texture, because that will tell you whether estrogen is switched off. And it largely stops the need for even undertaking repeated measurements of estrogen level. It will slow the growth rate a little bit, but the issue is that it stops the growth rate escalating, it flattens it out, and gradually it decreases the growth rate. It is not spectacular. It slows bone age advance, and it will likely improve moodiness and emotional lability. Treatment will not alter the growth of pubic hair, and most parents think that it will. It will not alter final height if it started above the age of 6 or 7 years. Equally, as I said before, this is very important from the family point of view, because most parents think that you're going to magically produce an extra 10 or 20 centimetres in their child's height, and that is totally incorrect. And it will not cause infertility, which is a concern for some families. It might reduce the risk for later polycystic ovary syndrome, and it may reduce the risk for future breast cancer by decreasing the amount of time that the breast is exposed to estrogen. So if we turn first to menstruation and then to a few cases, menstruation is something that we should all know about. The growth of the endometrium as we go through the follicular phase and the luteal phase before there's withdrawal of FSH and LH and loss of estrogen with loss of the endometrium. I'm always horrified and surprised that my endocrine fellows do not know about this. I think somebody forgot to tell them, but perhaps in other countries you're better informed. Normal menses usually last between 3 and 7 days with variable loss. They may be abnormal if they're abnormal, if you require menstrual pad or tampon changes less than every 2 hours, or whether the bleeding is associated with need for changes at night, flooding, other bleeding such as epistaxis. However, for the first 2 years after menarche, periods are unfortunately often heavy, irregular, and usually painless because they are not associated with ovulation. Menorrhagia is common and is usually associated with anovulatory cycles, but investigation should be considered for menorrhagia if there is a family history of menorrhagia. You should undertake a coagulation screen looking for factor deficiencies. And please remember that even a mild bleeding disorder, such as with von Willebrand factor deficiency, this incurs a very high risk of postpartum hemorrhage in future when these girls have children. 25% risk compared to about 5% in a normal girl. Acute treatment is very easy. You can use tranexamic acid, 500 milligrams 4 times a day for a smaller young person, or 1 gram 4 times a day if the child is over 50 kilos. Norethisterne acetate, 30 milligram per day for 3 days, 20 milligram per day for 10 days, and then 5 milligram per day for another 3 weeks will help to stop the bleeding, and then you would expect after you cease the medication that there will be a withdrawal bleed. Occasionally, you may need high-dose estrogen for 3 days, but that's very unusual. Chronically, for recurrent menorrhagia, again, you use tranexamic acid, non-steroidal anti-inflammatory agents, norethisterne, hydroxyprogesterone, or Depo-Provera. You may use the oral contraceptive pill if it's not too bad, because that should reduce the bleeding by around 50%. Where available, if there's chronic menorrhagia, a progesterone-bearing IUD is very helpful because it reduces menstrual loss, stabilizes the endometrium, reduces inflammatory cytokines and prostaglandins. So for many people who have a bleeding disorder, and remember that this can result in very early menarche as well, this is a wonderful option. Polymenorrhea is common due to a relative imbalance of estrogen and progesterone in the person who has just had the first bleed, probably around the age of 9 or 10 years. It's rare to have it associated with a polyp or tumour, and it's very easily treated with progesterone for 12 to 14 days every month. Bleeding disorders, while you will investigate for them, are also seen in some endocrine disorders, and the commonest of which is Noonan syndrome. Nearly 30% of girls with Noonan syndrome will have some abnormality of the von Willebrand factor or platelet function defects or some other cascade abnormality. So please remember that, because people often don't know about it. The bleeding disorders, which are really catastrophic and cause massive menorrhagia and polymenorrhea, are factor 5 and factor 8 deficiency, again can be treated with tranexamic acid, a contraceptive pill, but usually these ones require a progesterone-bearing IUD. For goodness sake, do not use depo-progestogen in patients with a bleeding disorder. They won't thank you for it. So if we think about oligomenorrhea, polycystic ovaries, we haven't got time to talk about it, but you know that hirsutism, acne, weight gain, oligoamenorrhea are the common symptoms. But the problem is that adolescents often have menstrual irregularity. Acne is common. A multicystic ovary, not a polycystic ovary, a multicystic ovary is usually normal. They're often symptomatic, and there's often acanthosis nigricans when the patient truly has PCOS. But mostly in an adolescent, even though they have a great deal of complaint, you won't see any biochemical or ultrasound abnormalities in the early years. So it may be just a diagnosis that's entirely clinical. And it can be treated, as you know, with menstrual regulation and treatment of the hair and weight management. But all these patients have high risks for complex problems of metabolic syndrome in future. Dysmenorrhea occurs because menstruation is an inflammatory process, and it's very common in adolescents, usually managed with aspirin or mefenamic acid and the contraceptive pill. But if there is continuing dysmenorrhea when taking the pill, this suggests a more serious problem that may need to be undertaken with management by a gynecologist. And it can be due to all sorts of problems ranging from endometriosis to genital tuberculosis, pelvic inflammatory disease, or a uterine polyp. So please don't just ignore it and say that a young girl with dysmenorrhea with her periods is just going to need an anti-inflammatory agent. If it continues, think of these complications. Conditions that are exacerbated by menstruation are legion throughout the gastrointestinal tract, the cardiovascular system, the endocrine, respiratory, neurologic, and immune systems always can be associated with menstruation. And sometimes it's through prostaglandins, but sometimes through other cytokines as well. If you suppress menstruation, you suppress the production of uterine cytokines and can improve the pain, but using the oral contraceptive pill in cycles does not do that because it's only suppressing it some of the time. You have to use long cycles of the contraceptive pill and cut off the sugar pills if it's going to be effective. So if we move now briefly to menstrual management in a child who has a disability, where there's difficulties in understanding hygiene, mood swings, plus major problems of exposure to unwanted sexual interaction with associated pregnancy risk in a postmenstrual girl. Your options for management are similar to other people, where you can use the contraceptive pill continuously, or a progestogen-bearing IUD, or depo-progestogen plus estrogen replacement, or implantable progestogen. So I'll go through some of these things. So there's a 4-year-old girl with a severe midline defect, moderate developmental delay, and rapidly progressive puberty, associated with rapid linear growth, an advanced bone age of 4 years, elevated gonadotropins, and that's obvious. You can treat her very easily with a GnRH agonist, and it will switch off the puberty. There's a 7-year-old girl with severe developmental delay, rapidly progressive puberty, but slow linear growth and weight gain, and a delayed bone age. There's your red flag. This child, although she has cerebral palsy, developmental delay, and rapid puberty, and you think, well, that's related to cerebral palsy, she obviously has hypothyroidism as well, and it's very easy to miss. So you don't want to miss this sort of thing. You need to both treat the hypothyroidism and then make sure that the associated ovarian cysts that have caused the precocity do not port, and that the whole problem does not result in secondary central activation, which will need to be treated with a GnRH agonist. So that's the sort of situation that arises when the patient presents very late. So here's a girl with Sturge-Weber syndrome, severe cerebral palsy, epilepsy, wheelchair-bound, non-verbal, moaning, miserable. She developed breast tissue at the age of 3, and now she's 7.5, and it all seems to have stopped. Her bone age is slightly advanced, and her mother is terrified about menstruation. You need to examine this child, make sure that there isn't another reason for her being totally miserable. She's got some major problem. She may well have a fracture somewhere. She may have a urinary tract infection or chronic constipation. It may not be the puberty that is the issue. And your action will be determined by your findings. You may need to do nothing. For this girl, she's probably better off having early puberty because it's good for her bone mass and it will reduce her fracture risk. However, when she's a bit older, when she does have menses, you'll be likely to need menstrual management as we've defined. More difficult is a child with autism and global developmental delay who's developed menarche at a reasonably normal time, but she finds the appearance of blood totally terrifying. Her behaviour is out of control socially, and things are not improving. So what are you going to do? Can we stop the periods? Will there be side effects? What about contraception? So then you're thinking about what's the best thing for all of these children. You need to balance up risk versus benefits for your patients. You can use the contraceptive pill in long cycles, but it may increase the risk for DVT if the child is stuck in a wheelchair with her knees bent all the time. Often these young people with a disability will be on multiple anticonvulsants, which increase hepatic estrogen excretion. And so that will change the excretion of estrogen and make the pill less effective. So they get breakthrough into menstrual bleeding using the pill. I don't find it a very helpful way of treatment. Depo-progestogen can be given every 12 weeks, but if the child is already at an age when you'll be wanting to accrue bone mass, like 11 to 13 years, the last thing you want to do is switch off the central axis. So you have to give estrogen as well to prevent loss of bone mass. In some countries, implantable progestogens are available. They deliver progestogen under the skin for 3 years, fairly low dose, but they do not switch off periods in more than 10% of the patients in whom they're given, and the disabled child is likely to try and pick out the little rod, so please don't use that either. And as I mentioned, the progesterone-bearing IUD is very successful. It will give up to 5 to 8 years of amenorrhea and contraception, the only disadvantage being that it requires a general anaesthetic for a few minutes for insertion. So we find that this is the best management. So is switching off puberty a good thing or a bad thing in girls with a disability? Having early puberty is great for bone mass accrual, reducing fracture risk. It helps some people with better understanding and communication. The disadvantages is that there's often emotional lability and mood changes. If the girl's able to understand there are physical differences from their peers can be a problem. And carer responsibilities are really difficult because often everybody except the mother find menstruation very difficult to manage. So we need to, when we're talking to families with children with a disability, we need to know what agenda are we dealing with? Are we dealing with the parents? Are they just concerned? Do they want to preserve height for their child, prevent menses? Are they just anxious? Is there some sort of peer pressure or carer pressure? Or are they trying to protect their child against sexual interference or sexualized behavior? So there are many options. So in summary, precocious puberty is a very common cause for endocrine reversal. There are many possible diagnoses. The age at onset and the rapidity of change are important clues as to investigation. You must have a careful history and a proper examination before trying to make a decision. And the consequences of your diagnosis and future risks may be very badly underestimated. And often these patients are not followed up for a sufficiently long time to be able to be properly cared for. If you are able to undertake a blood test and accurate imaging, that will help your accuracy of assessment, but you have to do that within the capacity that's available to you. It is complex and it's not simple, but we need to define where our concerns lie. Do not make any assumptions what families know or what the local doctor knows. Providing clear information on the basics of puberty and menstruation for families clears up their misconceptions and allows a reduction in anxiety. Try and pass on an expectation that we can deal with this problem for this family, and provide all the information in writing as well if it's available. And we have these booklets on puberty in children with disabilities particularly available in multiple languages. Thank you.
Thank you so much, Margaret, for that wonderful session, clarifying so many issues and keeping it very crisp. I think we have a couple of questions in the chat box. I think we have about 10 minutes to have a couple of questions. Dr. Shanoin is asking, how early would you start OCPs in a young girl with precocious puberty and irregular menses, and what dose would you use?
Depends on the age of the girl. I mean, if she has chosen to treat with GnRH agonist, I would normally treat with GnRH agonist up until usually around age 11 or when the girl is in grade 5. By that stage, I will ask the girl as well as the mother as to how she feels compared to other girls in the class and whether she feels able to cope with the puberty. At that age, I would not be considering using the contraceptive pill unless there was some reason. If she then develops menorrhagia or polymenorrhea, you need to remember to investigate that on its merits and make sure that she doesn't have a bleeding disorder. You may not have done that in the first place because she simply had precocious puberty, but you still need to undertake that investigation. Again, yes, a girl of 11 or 12 years who's had early puberty will be more mature than her peers, but she's unlikely in most cases to be undertaking grossly sexualized behaviour, unlikely to be exposed to unwanted sexual interaction, except in the case of, as we mentioned, children with a gross disability who are most unfortunately often abused. And even in the disability schools, I'm told by staff who work there that sexual interactions are out of control in those schools simply between the various students enrolled there. And so it is a huge, huge problem. Parents do not like to discuss it. They don't even like to think about it, let alone mention it. But they're always very grateful if you mention it and discuss it with them. So your question, to answer it, there was a long way of answering it, was that if the girl answers any of those questions, menorrhagia, polymenorrhea, a question of sexual interactions for one reason or another, I don't think it matters at what age after 11 to 12 you start offering the pill, because she already has adult levels of estrogen. So you're not doing anything to the girl that is not already present. You're not giving extra estrogen. I would always use a low-dose estrogen. The risks, such as they are for procoagulopathic situation, is increased with the higher doses. So I would pick a 30 microgram oral contraceptive pill as a start.
Just a small extension to this question. So in your presentation, when you said usually when the menarche happens after 8+ years, it's usually we don't really have to use general analogs to control that. What if that particular child at 8.5 and 9 years has irregular or polymenorrhea or hypomenorrhea? So what would be the right thing? Do we use OCPs or do we actually go with general analogs?
I would use progesterone.
Progesterone.
If the child is completely through puberty, got stage 4-5 breast development, pubic hair, achieved something near the mid-parental expectation, you're not going to do anything effective by using massively expensive GnRH agonist. It's not effective for anybody at that age. So I would use probably 20 milligrams of medroxyprogesterone acetate per day. You might get away with 10, but you'll probably need 20. And that will effectively switch off periods for as long as it takes.
A longer continuous course.
Yes.
Got that. I have another quick question. Dr. Rai Kurnia asks, they have several patients and chronic diseases, leukemia, SLE, on chemotherapy, steroids, etc., etc. So they develop secondary amenorrhea for 3 to 6 months. So they do have some, when examined, they have normal levels of FSH, LH, estrogen. So how long do we observe, or when do we start treatment for that?
There are a number of issues for somebody having leukemia treatment. Firstly, people have tried using GnRH agonist to switch off menstruation and switch off, so they switch off menstruation so that they don't exacerbate anemia. They switch off puberty in an effort to save oocytes, and that is relatively ineffective in humans. It's great in mice. It is very ineffective in humans, so it's probably not particularly valuable. The second thing is that the chemo, less so just acute leukemia, maybe more likely with conditioning prior to a bone marrow transplant, but the more toxic your gonadotropin, the more likely you are to precipitate acute ovarian failure. So you have to be very careful between considering that because periods have disappeared, that they are disappeared because the child is sick, because you're giving some progesterone. You may actually switch that suddenly to primary ovarian failure. And because cancer doctors are treating cancer and curing cancer, they never ever think about the fact that this poor girl is now losing half her bone mass and feeling absolutely. So you may need to do the opposite. You may need to add back estrogen and use the oral contraceptive pill. You could use any pill you like, again, always choosing the lower dose that has no side effects. But you may need to do one thing to switch from one to the other in terms of your diagnosis. You need to remember that the risk for fracture is increased about 7 times above others during leukemia treatment, partly because there's so much marrow infiltration with leukemic cells that increases the bone fragility, particularly in the axial skeleton. But at the end of leukemia treatment, assuming that the patient is cured, the bone density goes back more or less to normal.
Right. A quick question, how early can we use the progestenated IUDs? It's the earliest age we can use hormone IUDs.
I think in general, progesterone-bearing IUDs are becoming more and more commonly chosen where they're available. So you have to have enough money to be able to purchase them if your institution is not able to provide them for the patient. But in the long term, they're actually cheaper because you have no periods, no medications, and they last for, these days, nearly 8 years between changes. The only thing that is required is that the uterus is a full adult size, and that means that the patient has achieved menarche. They cannot be used until the uterus is a full size. We used to do a uterine sounding to make sure that the uterine length was 7 centimetres internally before you could use it, but we don't do that anymore because we are well aware that unlike the old IUDs, the progestogen-bearing ones are usually not extruded, and once the girl has achieved menarche, her uterus is adult size.
I think we'll have one last question from Dr. Raghupati. A 15-month-old girl with monthly cyclic vaginal bleeding for 6 months with no breast development or axillary pubic hair, and a pubertal response in GnRH stimulation test. MRI normal, and there are nothing suggestive of peripheral precocity as of now, like there are no capillary spots and bony lesions. Should we take this as idiopathic sentinel precocity? Apparently, there is a cyclical vaginal bleeding with no breast changes, the positive GnRH test.
Totally terrifying situation because you're fairly certain that there's something dreadful wrong and you can't find it. I would be doing 3 to 6 monthly MRIs if that were possible, looking for the germinoma. It would be very unusual, having said that, in that age group for not unusual for germinoma necessarily to be present, although they tend to be in the older age group, sort of 4 to 5 years plus. But there's usually, in babies, whatever they have are usually big, rapidly growing lesions. The situation that you describe is almost always that of McCune-Albright syndrome. And it may be that this child has a GNAS mutation that is so powerful that it has already given central secondary central stimulation. And not everybody with a GNAS mutation has cafe-au-lait marks. I mean, that would be the typical finding. You're just unlucky you've missed the cafe-au-lait marks.
Right.
Really also impossible to deal with.
Thank you so much for the wonderful session. I think our time is up, so we'll hand it over to the managers. Thank you so much, Marjorie.
This meeting is being recorded.
Okay. Hi, everyone. This is Sonir Antonini from the University of São Paulo in Ribeirão Preto Medical School in Brazil. And I'm very glad to be here with you today. And also, I would like to thank the organizing committee of GPED for organizing this awesome meeting. And to start our adrenal session this morning, I would like to introduce you Dr. Salwa Musa. Dr. Salwa is a pediatric endocrinologist from Sudan, and she will be presenting us the conference entitled AAA Syndrome, a cohort with 43 patients from Sudan. Dr. Salwa Musa, please.
Hello? Is it clear now?
Yes, I can hear you clear. Yes.
Okay. So thank you, Dr. Samir, for the introduction. I'm Salwa Musa, pediatric endocrinologist from Sudan. And I would like to start this presentation by thanking the organizing committee for giving me such opportunity to be here today in the first GPED annual meeting and to share our experience in a very rare syndrome named Algrove syndrome, with particular focus on our cases from Sudan. I have nothing to disclose. The outline of my talk will begin with an overview of Algrove syndrome and the current knowledge surrounding it. Then I will move to some case scenarios to highlight and illustrate the clinical features unique to this syndrome. Then we'll move to discuss some rare features and the clinical heterogeneity in Algrove syndrome patients. And then I will end by discussing our series from Sudan. So Algrove syndrome, or AAA syndrome, is a clinical multisystem disorder firstly reported by Algrove et al. In 1978, and it has autosomal recessive inheritance due to mutation in AS gene encoding the allogeneic protein. And this syndrome composed of triad of alacrima, achalasia, and adrenal insufficiency, hence the name AAA syndrome. But with time, more neurological features and 2/3 of patients develop neurological feature prompted some author to suggest the name 4A syndrome. So regarding the genetics of this syndrome, a biallelic mutation in AS gene encoding a 546 amino acid protein called allogeneic is implicated in the pathogenesis of this syndrome. And allogeneic protein is localized to the nuclear pore complex that mediates transport of macromolecules between the cytoplasm and nucleoplasm. And actually, very interestingly, that the name Aladdin is related to the fictional character from the Middle East folktale portrayed a young man whose story revolves around the magical lamp. Where wrapped, the lamp summons a powerful genie who performs magic and helps fulfill his dreams. And similarly, this protein functions in a way that produces significant and multiple effects. So these effects include a role in cell division, cytoplasmic trafficking, normal peroxisomal function, and redox hemostasis in human adrenal cells and steroidogenesis. And hence, this syndrome has an autosomal recessive inheritance. The recurrence risk in future pregnancies is approximately 25%, and more than 70 mutations were identified up to date. So there is no common pathological features common to the three sites affected in Algrove syndrome, but it has been shown that high expression of allogeneic in different tissue lead to multisystem involvement seen in Algrove syndrome patients. And as we previously mentioned, that allogeneic plays a very big role in the cell hemostasis in adrenal functions. Mutation in this gene could lead to impaired redox hemostasis and also reduce the biosynthesis of precursor metabolites needs or required for glucocorticoid and androgen production. Also, it has been shown that oxidative stress play a role in the pathophysiology of this syndrome. An increase oxidative stress and due to increase in the reactive oxygen species could be implicated in the pathogenesis of this syndrome, leading to adrenal dysfunction and destruction. And decrease also DNA repair and protection of cells against oxidative stress have been implicated in the pathophysiology of this syndrome. So regarding clinical presentation, this syndrome actually the clinical features of this syndrome are progressive, indicating degenerative process, and the age of onset is quite variable, where lacrima presented in early infancy and so consistent signs, while achalasia varies, presented very early as 6 months or as late as early adulthood. ACTH resistance adrenal insufficiency not present at birth, but develops over time, usually in the first 2 decades of life and mainly in the first 10 years of life. And the above complete triad were present in 70% of cases, while autonomic dysfunction present in 1/3 of patients. Other include neurological, dermatological, and other dysmorphic features. So closer look to this syndrome and its feature, we can see that dysmorphic features include narrow face, long philtrum, down-tail mouth, large ears, and microcephaly, while ophthalmological include alacrima, hypolacrima, optic atrophy, and ischemia, which is abnormal pupillary response. Oral and dental manifestation includes dystomia, fissure tongue, dental caries, and fungal infections. While GIT manifestation include achalasia, dysphagia, which all could lead to regurgitation, failure to thrive, and chronic respiratory symptoms. Neurological manifestations are wide, including motor, sensory, and autonomic dysfunction. And endocrine manifestations include glucocorticoid deficiency and to a lesser extent, mineralocorticoid deficiency, osteoporosis, and short stature. Other dermatological manifestations include hyperpigmentation, palmoplantar hyperkeratosis, and cutis and serine. So despite these features are very clear, yet the diagnosis is considered challenging, given the rarity of this syndrome and the diversity of clinical features. But the presence of 2 out of 3 cardinal clinical features strongly suggests the diagnosis of Algrove syndrome. And the most frequent initial presentation is hypoglycemic adrenal crisis secondary to glucocorticoid deficiency. Differential diagnosis including adrenal dystrophy due to neurological manifestation or familial glucocorticoid deficiency due to preservation of mineralocorticoid function in most of the patient and other types of adrenal insufficiency. Since patients of Algrove syndrome presented with undiagnosed alacrima, most of patients of Algrove syndrome are liable to keratoconjunctivitis sicca and other keratopathies. Achalasia also could lead to recurrent aspiration, acute pneumonitis, choking, or even death. Autonomic dysfunction, including Parkinsonism and other slowly progressive neurological manifestations, have been seen in patients with Algrove syndrome. And also complication of management, which include complication of the medications like glucocorticoid therapy, like growth failure, Cushing syndrome in overtreated patients, or adrenal crisis in those who are undertreated. And the prognosis is considered highly dependent on early diagnosis to prevent life-threatening adrenal insufficiency, while normal lifespan and childbirth are possible, despite some cases of infertility have been reported, which necessitate further research. Primary cause of death remain a recognized adrenal crisis. So now let's move to some case scenarios to explore more features of this syndrome. So case 1 is a 6-year-old boy who was referred to us because of the abnormal thyroid function test. He has history of generalized fatigability and decreased activity over the last 6 months. And then he has recurrent attacks of abdominal pain, which misinterpreted as gastroenteritis. And he has normal examination apart from a scar on his face that hasn't resolved over the past 3 months. And on repeated workup, he has normal thyroid function test and normal electrolytes. And you can see here the boy, and there is mild hyperpigmented scar on his face. And due to burden of the adrenal insufficiency in our community and Algrove syndrome, we immediately suspected that this child could have Algrove syndrome or adrenal insufficiency. So we asked the mother about alacrima, and she noticed that there is absence of tears, at which she sought medical advice many times, but she was reassured. Then we moved to cortisol, which was very low, 4 microgram per deciliter with high ACTH, confirming diagnosis of primary adrenal insufficiency, and shimmer test confirmed the presence of alacrima. Management and counseling were initiated. So when we say hyperpigmentation, is it like constant sign in patients with Algrove syndrome, and could it be resolved like other cases of adrenal insufficiency? You can see here different degrees of hyperpigmentation, which could be generalized in the palms and soles, or even at the site of scars. So from our experience, we can say that hyperpigmentation could be an alarming sign of primary adrenal insufficiency, which is constant with various degrees. But suppression of plasma ACTH level with physiological doses of glucocorticoids in patients with Algrove syndrome usually not achieved, and hyperpigmentation might persist in cases of Algrove syndrome. So it's unclear why ACTH is not fully suppressible in those patients. But anyhow, attempts to suppress ACTH level with supraphysiological doses of glucocorticoids must be avoided to prevent overtreatment. Moving to alacrima, which is the most common and early feature of Algrove syndrome, but it's usually overlooked, and its usual past are recognized. But at the time of presentation, we could notice like conjunctival ingestion, redness, irritation, which would be the only obvious signs. Shimmer test was used to confirm the presence of reduced or absent tears, and orbital CT scan could reveal absence or decreased lacrimal glands. Slit lamp examination is also useful to reveal punctate keratopathy or corneal ulceration. And alacrima and optic nerve atrophy, both of them could be considered as part of autonomic dysfunction, which is indicated by the neuronal degeneration which found in the lacrimal gland biopsy in Algrove syndrome patients. And here is the shimmer test, which indicate the alacrima. If we found like it's less than 5, this indicates severe alacrima. Between 5 and 10, this is moderate, and more than 10, it's severe. So here we could say that since isolated alacrima is a rare condition, crying without tears is considered as an alarming sign suggestive of Algrove syndrome. And we should routinely inquire about tear production in any child presented with adrenal insufficiency or in a family with a confirmed diagnosis of Algrove syndrome. Moving to case 2, which explores diversity of presentation between the patient within the same family. Here are 2 siblings who presented with features of Algrove syndrome since early age. And you can see here that there is a difference in the growth rate between the 2 siblings. The elder sibling, which is a girl, she presented with severe achalasia, which is indicated here, as you can see in the barium swallow, and severe growth hernia state several admissions, while the boy had preserved GIT symptoms. And you can see that those siblings have the same mutation. So this indicates that adrenal insufficiency or Algrove syndrome could be has very variable presentation even within the same family. So regarding achalasia, it's defined as failure of lower esophageal sphincter to relax, and it's uncommon disorder, more rare in childhood. And incidence of glucocorticoid deficiency in patients with isolated achalasia is considered low. So endocrine evaluation is not warranted unless the patient has primary insufficiency symptoms, and this is reversed to alacrima. So symptoms of achalasia include regurgitation, dysphagia, and other respiratory symptoms, and diagnosis usually achieved by barium oesophagography, esophageal manometry, and endoscopy, while management include pneumatic dilatation, anterior cardiomyotomy by modified Hiller operation, or perioral endoscopic myotomy. Moving to case 3, which is considered unique as it showed one of the very rare features. 3 siblings, aged 5, 4, 2 years, presented with hyperpigmentation and adrenal crisis. Both male siblings presented with features suggestive of adrenal crisis, while the girl exhibited the same feature but 3 years later. And you can see here at diagnosis, all siblings presented with alacrima, none had achalasia, and the girl has normal adrenal function, while the youngest sibling had low sodium, high potassium, indicating mineralocorticoid affection. So we could say that adrenal insufficiency is the main presentation that brings patient to medical attention, and it affects up to 80 to 100% of patients with AAA syndrome. And it's usually manifest during the first or more rarely the second decade of life. And it doesn't appear to be congenital like in this girl. And it's the main cause of mortality among patients with Algrove syndrome, mostly due to severe hypoglycemic crisis. So lifelong follow-up of patients with initially normal or borderline adrenal function is warranted, like in our girl who had normal adrenal function at presentation and then she developed severe adrenal crisis later in life. So back to our case, we said that this child is having, the youngest sibling having some sort of mineralocorticoid deficiency. And since Algrove syndrome is considered one of the ACTH resistant syndrome with preservation of mineralocorticoid function, yet 15% might develop mineralocorticoid deficiency, and that is due to destruction of the zona glomerulosa due to increased oxidative stress. Back to our case, 2 years later, the elder sibling, which is 7 years at that time, presented with fever convulsion for 3 weeks, who diagnosed as meningoencephalitis. Then at presentation, he was very ill, unconscious, and he has very high blood pressure. An MRI showed cortical infarction. The younger sibling, who had 6 years at that time, presented with the same feature at the same time, but he developed sudden loss of vision. So the common feature between 2 siblings is fever, convulsions, and high blood pressure. So many questions was raised at that time. What was the cause of neurological insult in both siblings? And if you consider it like infection or meningoencephalitis, why do they develop hypertension in both siblings at the same time? And if it is neurological insult that is related to Algrove syndrome, why did they present with it at the same time? And again, could it be part of autonomic disturbance seen in patients with Algrove syndrome? Actually, these questions remain without answers. So regarding autonomic dysfunction, which found in third of patients with Algorov syndrome, and symptoms include postural hypotension, hypertension, arrhythmias, among others, and it's very difficult to be managed. And hypertensive encephalopathy was documented in one case report of Algorov syndrome, and the second is our two siblings. So move to case 4, which highlight the common feature which could be misinterpreted as a common diagnosis, and this will lead to delayed diagnosis. A 5-year-old male referred from the neurology department as he was followed with them for the last 3 years at the case of developmental delay, global developmental delay with recurrent seizure, which is not hypoglycemic in origin. He presented lately at the 1 month ago with hyperpigmentation, and then at that time they suspected adrenoleukodystrophy, and they referred this case to us. He had lacrimal birth, delayed teeth eruption, global developmental delay as he walked at the age of 5 years. And you can see here that the boy is having some clinical features of Algorov syndrome, including hyperpigmentation, large ears, microcephaly, and this hyperpigmentation actually resolved after treatment of 2 years. So regarding neurological manifestation of patients with Algorov syndrome, the pathophysiology remain unknown, and its variable involved peripheral, autonomic, and motor nervous system, and the neurodegenerative process was observed in 60% of patients. So it's typically manifest in the second decade of life or adulthood, but in some reports it could present as early as childhood, like in our cases, and seizures have also been attributed to hypoglycemia, but not in our patient, which hypoglycemia was excluded. And also developmental delay could be one of the rare manifestation of neurological manifestation in patients with Algorov syndrome. So the last case would be very complicated actually, because it exhibited all features of Algorov syndrome and beside other features. So he's a 13-year-old male with normal development up to 5 years of age, who has excessive nasal secretion and dysphagia, which is the main concern for the family. He also developed abnormal gait and difficult walking, and lacrima was noted since birth, but he received no treatment, and hyperpigmentation was also observed, but was not of concern for the family, though they report that he became more darker than his peers. At the age of 10 years, dysphagia and difficulty swallowing progressed, and he became unable to walk unsupported. MRI at that time was normal, and duodenal biopsy indicated a follicular duodenitis. CT nasopharynx, because of excessive nasal secretion, was done, and it revealed adenoid enlargement, and he received only supported treatment. And then he presented with hypoglycemic crisis at the age of 12 years. And at that time, all clinical and biochemical features was very suggestive of Algorov syndrome. And you can see here that this is the boy at presentation. He's so hyperpigmented and having all features beside depression and psychological disturbances, including anxiety. I'm very fortunate that we could be able to diagnose other two siblings who presented with the same features at the early time, so we could preserve the development of or progression of the neurological manifestation. So regarding the neuropsychological disturbances seen in patients with Algorov syndrome, it could range from mild intellectual disability, maybe due to recurrent hypoglycemia, to low IQ and impaired intelligence. Anxiety and affective mood disorder was also observed in patients with Algorov syndrome, and it's really progressive and should be evaluated very regularly. Very unfortunately, that glucocorticoid therapy does not seem to affect the development and the course of neurological manifestation, as in our patient, and physiotherapy sessions may help to improve the patient who experience neuromuscular symptoms. So by this, we finished our cases, and hopefully we could elicit and explore the clinical features in this syndrome. Now moving to clinical heterogeneity seen in patients with Algorov syndrome patient. Actually, the presentation of Algorov syndrome is quite heterogeneous. As you can see from the age of presentation, it's quite variable even between the patient from the same family. This is as symptoms at presentation. And if we exclude lacrima, which is a consistent time developed in early infancy, other features are quite variable between this patient within the same family. And this also includes the frequency of symptoms and the course of the disease. And there is no genotype for phenotype correlation has been identified in Algorov syndrome patients. Other rare presentations include osteoporosis, short stature, delayed puberty, and microcephaly as dysmorphisms associated frequently with patients with Algorov syndrome. Delayed speech also has been observed in patients with Algorov syndrome due to various reasons. And this is different from the nasal tone of voice, which is very common features of Algorov syndrome. Small spastic fissure tongue is very characteristics of Algorov syndrome, as you can see in this boy. So when we take a patient with Algorov syndrome, we should there is many management and follow-up consideration in patients with Algorov syndrome, like how do we guide the treatment, which need multidisciplinary team and the eye care to prevent the early complication, What about the mineralocorticoid replacement and how we could monitor the treatment and the follow-up visit and frequency, especially for patients who had confirmed genetic diagnosis and normal adrenal functions. So now moving to the last part of this presentation regarding the Algorov syndrome in Sudanese population. So as we know that Algorov syndrome is a very rare disorder, and actually the prevalence of 1 in 1 million population, but the incidence is quite variable due to variable presentation. Regarding Sudan, Sudan is a country sited in Northeast Africa with very diverse kind of population, and the high rate of consanguinity and variable ethnic groups could lead to high burden of certain genetic condition in certain tribes like Algorov syndrome. So we observed that from our study in 2017 that Algorov syndrome is the commonest non-CH primary insufficiency in our community. And then we reported this in 2020 when we found that actually more than third of our patients with non-CH primary insufficiency have Algorov syndrome. And this actually just the tip of the iceberg, as many families reported many children who have the same feature who pass undiagnosed with the similar features. And also they reported the similar patient with a similar feature in the community who needs further evaluation. So regarding our cohort from Sudan, reported cohort, we have 46 patients from 31 families who reviewed, of which 31 patients from 20 families underwent genetic analysis, and 6 have different mutation with 2 novel mutations identified. And we found that hyperpigmentation is a cardinal feature presented at the time of primary insufficiency, while elacrima was a consistent universal finding in all patients noticed since birth. This is considered the largest cohort with genetic analysis from sub-Saharan Africa and Arab countries. And here you can see the diversity of clinical presentation in patients with Algorov syndrome, including many common features and many very rare features. So what was our challenge in diagnosis and management? We have very poor healthcare system, especially in remote areas, and now the burden of the recent war has increased the burden of the poor healthcare system. Also, we have lack of awareness among professionals and community regarding this rare syndrome. We have also lack of diagnostic facilities and their cost as well. There is also difficult access to medicine like hydrocortisone and fludrocortisone and therapy supply, and this is actually universal to many African countries. And there is also lack of multidisciplinary team specialized at this syndrome and rehabilitation facilities, and there is no consensus guidelines for follow-up, especially for patients with normal adrenal functions. So I could say here, I could summarize and say that Algorov syndrome is not uncommon, with a wide range of variable presentation, even in siblings from the same family, and should be suspected in any child with elacrima and hyperpigmentation. And raising awareness is essential, leading to early detection and management of primary adrenal insufficiency cases. But the main message is, whenever you see patients with these symptoms, elacrima or hypolacrima, and features of adrenal insufficiency, achalasia or difficulty swallowing, especially in young children, adrenal insufficiency evident by hypoglycemic crisis, and also autonomic and neurological dysfunction in any patient with primary adrenal insufficiency, always remember Algorov syndrome. And here is Professor Jeremy Algorov, who expanded our knowledge about this syndrome by discovering this rare syndrome in 1978. And actually, by raising the awareness and bringing more patients to medical attention, we could also, all of us could contribute to increase awareness about this rare syndrome. And finally, I would like to acknowledge my colleagues who are now residing in Sudan, facing difficulties to manage patients with Algorov syndrome and other rare disorders, our patients and their families during this tough time in Sudan. And I ask you all to pray for Sudan during this difficult time. Thank you very much, and thank you for listening. Have a nice day.
Thank you, Dr. Salma. It was really interesting report from so many patients from one country. I would like to say that to attendees, if they have questions, they can go to the feedloop chat and send their questions, and then I can transmit to Dr. Salma. Meanwhile, I will, let me see if someone has, there's one question that has arrived. What is the mean age of diagnosis in your country? Does the time of primary adrenal insufficiency diagnosis depend on the mutation in your experience?
Okay, so the mean age of presentation actually is around the age of 7 years, okay? But it's very variable because it could be as early as 2 months of age and as late as 17 years of age. So it's quite variable. we couldn't say like its mean age of presentation because it's quite variable, even between the patient from the same family. Like you can find in the same family, patient who presented early in infancy with adrenal crisis and patient who presented very late.
Okay, so the second question from the audience would be if the age of the appearance of the adrenal insufficiency depending on the type of mutation, because you said that you had 6 different mutations. Did you observe that any specific mutation? No correlation.
No correlation. No genetic, no phenotype correlation between these, between presentation and the specific type of mutation.
Yeah. And this is another question that comes from Colombia in South America. Comes from they say that in Colombia they have 28 patients with Alport syndrome, and 100% of them, all of them have they present with a lacrima and achalasia, and also adrenal insufficiency. But different from it, you said that in your cohort had 15% of the patients with mineralocorticoid deficiency, but in the experience in Colombia, they show that up to 72% of the patients, the Colombian patients, they do present with mineralocorticoid deficiency as well. So it appears that in your cohort, you see 15% of mineralocorticoid deficiency, and in this Colombian cohort, it's much more the higher prevalence of mineralocorticoid deficiency.
So yes, mineralocorticoid affection in patients with Alport syndrome, as I mentioned, that Alport syndrome is mainly ACTH resistant syndrome. So the main presentation with mineralocorticoid deficiency and mineralocorticoid deficiency could be observed. And the cause of mineralocorticoid deficiency in patients with Alport syndrome is the zona glomerulosa affection, which could be very late in the course of the disease. Okay, so they might have late presentation, for example. Okay, this could be justified, but also mineralocorticoid deficiency could be observed in patients who have early diagnosis. So it's really not known why those patients present with mineralocorticoid deficiency. It's just theories.
Yeah, this is very interesting. This high percentage of mineralocorticoid deficiency, I would not expect, though. This is something that should be addressed in future research, right? And then the question from Dr. Muha Sharaf, that according to your experience, they say that she or he says, I have a patient with AAA. I did ACTH stimulation test and cortisol still normal. What of the frequency that you recommend to monitoring of ACTH and cortisol each 6 months or
yes,
for example?
Usually because the time at the patient develop adrenal insufficiency is very quick. So we usually do it cortisol monitoring every 6 months to prevent the adrenal crisis. And usually we also aware the parents that if you notice that this patient is developing hyperpigmentation, just come to the medical attention immediately.
Okay. Yes. So the last question is from this Dr. Shahab as well. If there is any indication for growth hormone replacement in these patients?
I didn't came across growth hormone indication in patients with Alport syndrome because it's the growth failure and delayed puberty, the pathophysiology is not well known. So we couldn't say it's one of the indication for growth hormone treatment.
Okay. I think this was the last question. Thank you very much, Dr. Salwa. Thank you very much.
Thank you. Thank you.
So our next speaker will be Dr. Régis Coutin. Dr. Régis Coutin is a professor of pediatrics at the University of Angers School of Medicine in France. And he will be speaking to us how to simplify the diagnosis of Cushing's syndrome and Cushing's disease as well. Please, Dr. Régis.
Thank you for your kind presentation. I will try to share my presentation here now. Okay. Is it okay for you?
Yes, the screen is fine and your voice is clear.
So, okay, thanks. So good afternoon to everyone. And thanks to the organizing committee for this kind invitation. I have no conflict of interest in relation to the presentation. So what signs and what tools? There are many clinical signs that can point to Cushing syndrome, as you know. No single sign is very specific. Numerous tools have been proposed for positive or causal diagnosis, such as hormone measurements at baseline, upon suppression, upon stimulation, such as anatomical imaging, MRI or CT scans, such as functional imaging, somatostatin analogs, FDG, FDOPA, PET, combined with CT scans. This plethora of tests has been developed because a single test often fails to produce a positive or causal diagnosis, but this can pose problems of prioritization on the one hand and availability on the other. As a clinician, I will try to give you a hierarchy based on the sensitivity specificity of the tools. The positive predictive value and the negative predictive value will also depend on the frequency of the different causes of Cushing syndrome. So first question, who should be tested? Sorry. In a Danish nationwide registry, the annual incidence of Cushing syndrome was less than 1 for 1 million children. 70 to 80% of cases were Cushing's disease, 20 to 30% were adrenal Cushing syndrome, and less than 1% were ectopic Cushing syndrome. You can see here a typical case of Cushing's disease with changes in facial features, slowed growth, and increased weight. In some cases, it may be useful to get past photographs of the face to objectify the morphological changes. In 2021, the features of Cushing syndrome were present in this girl, but without a typical striae. The earlier photo helped us to observe the rapid morphological changes. In this case, the boy had a small stature, 2 standard deviation scores below his genetic target height, but this was very ancient, while the increase in weight was more recent. He had a rounded face, but we were elay. The point is, when there is a discordance between height and weight, even if discrete, test for Cushing syndrome. This case may be a trap, since the child was not obese at the start of the growth retardation. The slowed growth contrasted with the maintained weight gain. There was a gradual rounding of the face, but this may not be obvious if you look only the last pictures without past photos. This study by Patsy et al., an American study by the National Institute of Child Health and Human Development, collected data on 273 children with Cushing syndrome. The mean age at diagnosis was younger for adrenal causes. The height and BMI at diagnosis were similar between adrenal Cushing syndrome, Cushing's disease, and ectopic Cushing syndrome. And notably, about 30% of the children were non-obese. Were non-obese at diagnosis, but had markedly slowed growth. So the first take-home message will be, look for Cushing syndrome in children who show a discrepancy between slowed growth and increased weight, even if it is not marked. Look for facial morphological changes in recent years, as well as striae. At the end of puberty and growth, look for unexplained weight gain and morphological changes. And finally, do not look for Cushing syndrome in obese children with a long history of obesity and perfect growth. Question 2. What are the tools for positive diagnosis of Cushing syndrome? In this study by Batista et al. From Professor Stratakis' group, in a large group of children, a single measurement of 24-hour urinary free cortisol provided a sensitivity of 94% and a specificity of 90% for Cushing's disease. The mean of 3 UFC provided a sensitivity of and a specificity of 100% for Cushing syndrome, either Cushing's disease or adrenal Cushing syndrome. The cutoff for diagnosis was 70 micrograms per square meter of body surface area per day. However, in practice, it is necessary to be able to ensure that a 24-hour collection the 24-hour collection of urine is complete. Other available tools are the overnight dexamethasone suppression test and the midnight plasma and salivary cortisol measurement. In contrast to adults, there are not many studies on the sensitivity and specificity of the overnight low-dose dexamethasone suppression test in children. In adults, a cutoff of 1.8 microgram per deciliter, 5 nanomole per liter, gave a sensitivity of 98%, but a specificity of 90%. As some of this low specificity has been attributed to the stimulatory effect of estrogens on cortisol binding globulin, specificity in children who are less exposed to estrogens may be higher. Several studies have shown that midnight plasma cortisol is the best test with a cutoff of 4.5 microgram per deciliter, as shown in this study by Batista, with sensitivity and specificity close to 100% for Cushing's disease and adrenal Cushing syndrome compared to control groups. Similarly, but studied in a few dozen children, a midnight salivary cortisol cutoff of 7.5 to 8 nanomole per liter was perfectly sensitive and specific, as shown in this reconstructed figure from the study from Ballerini et al. So the take-home message number 2 is, in a child suspected of having Cushing syndrome, perform at least 2 UFC or 1 UFC and 1 overnight dexamethasone suppression test. In equivocal cases, midnight plasma or salivary cortisol measurements are highly sensitive and specific, but generally less readily available, and in equivocal cases, repeat testing over time. Question 3, how to prioritize etiological diagnostic tools? The first step would be to measure ACTH at 8 hours in the morning. In this study by Tatsi et al., morning ACTH, a morning ACTH of less than 5 picogram per milliliter establishes the diagnosis of ACTH-independent Cushing syndrome with perfect specificity. All adrenal Cushing syndrome had, meaning that when an ACTH was less than 5 picogram per milliliter, it was always an adrenal Cushing syndrome. And in that case, an adrenal CT scan is therefore necessary. When morning ACTH is greater than 30 picogram per milliliter, the diagnosis of ACTH-dependent Cushing syndrome is made with perfect specificity. No adrenal Cushing syndrome had a morning ACTH value greater than 30, and pituitary MRI is therefore necessary. And when morning ACTH is between 5 and 30 picogram per milliliter, an adrenal CT scan and pituitary MRI are usually necessary, and other hormonal tests are usually useful. the percentage of children with adrenal Cushing syndrome with ACTH between 5 and 30 picogram per milliliter is about 25%, and the percentage of children with Cushing's disease with ACTH between 5 and 30 picogram per milliliter is about 25%. However, since Cushing's disease corresponds to 80% of Cushing syndrome and adrenal Cushing syndrome to 20%, the probability of Cushing's disease in this situation is 4 times higher than that of adrenal Cushing syndrome. The probability of ectopic Cushing syndrome with ACTH between 5 and 30 is about 0, because ACTH levels are usually higher with ectopic Cushing syndrome, but the number of ectopic Cushing syndrome is very small. We will see this later. So at this stage, a probabilistic approach needs to be taken. This is a take-home message number 3. If ACTH level is over 30 picogram per milliliter, it is a Cushing's disease with an estimated probability over 97%. Ectopic Cushing syndrome is exceptional, so you have to perform a pituitary MRI first. If 8-hour ACTH level is between 5 and 30 picogram per milliliter, it is a Cushing disease with an estimated probability of 80% versus adrenal Cushing syndrome. So you have to perform a pituitary MRI and an adrenal CT scan. The probability of ectopic Cushing syndrome in this case, ACTH between 5 and 30, is very, very low. And finally, if 8-hour ACTH level is below 5 picogram per milliliter, it is an adrenal Cushing syndrome with an estimated probability of 100%, so you have to perform an adrenal CT scan. Question 4, how to prioritize etiological diagnostic tools? The next step would be imaging. If it is a Cushing's disease, in children, the probability of finding an adenoma on pituitary MRI is about 63%. A negative pituitary MRI does not exclude the diagnosis of Cushing's disease, which remains the most likely, more than 80%, even if the pituitary MRI is negative. Recently, some studies in adults have shown that dynamic MRI could localize an adenoma in 83% of cases of Cushing's disease. I will show you dynamic MRI on the next slide. If there is any doubt as to whether Cushing syndrome is ACTH dependent or ACTH independent, when ACTH ranges from 5 to 30 picogram per milliliter, an adrenal CT scan can rule out an adrenal cause in 100% of children with Cushing's disease. You can see here dynamic pituitary imaging, which is a dynamic sequence based on T1, and which comprises one pre-contrast acquisition followed by post-contrast acquisitions. Between the measurement, there is 8 to 13 seconds interval. You can see here on the right part of the pituitary, the adenoma with a defect in the contrast. Let's see now when the 8-hour ACTH is below 30 picogram per milliliter. An adrenal CT scan has to be performed. If it is an adrenal Cushing syndrome, the probability of finding nodules or a tumor on adrenal CT scan is about 72%. Other cases were primary pigmented nodular adrenal disease or micronodular adrenal disease, which are very rare diseases. And in that case, if you perform also a pituitary MRI, the false positive rate, that is finding an image that is not an image on pituitary MRI that is not a Cushing's disease, would be around 8%. This is the false positive rate of pituitary MRI in case of adrenal Cushing syndrome. So the take-home message number 4, this is still a probabilistic approach for the diagnosis. With 8-hour ACTH measurements, pituitary MRI, and adrenal CT scan, a causal diagnosis of certainty, either Cushing's disease or adrenal Cushing syndrome, is made in around 65 to 70% of cases. Uncertain causal diagnosis, if the 8-hour ACTH level is over 30 picogram per milliliter and pituitary MRI is negative, in that case, the probability of Cushing's disease is still around 90%, and that of ectopic Cushing syndrome is around 10%. So you have to screen for ectopic Cushing syndrome, but you have to know that ectopic Cushing syndrome, even in this situation, is very rare. And the last uncertain causal diagnostic situation is if the 8-hour ACTH level is between 5 and 30 picogram per milliliter, and pituitary MRI and adrenal CT scans are both negative. The probability of Cushing's disease, in this case, is more than 80%. That of adrenal Cushing syndrome is less than 20%, and that of ectopic Cushing syndrome is close to 0, because for ectopic Cushing syndrome, most of the ACTH levels are over 30 picogram per milliliter. So the next question is what to do in equivocal cases. We will see the first equivocal case, 8-hour ACTH level over 30 picogram per milliliter and negative pituitary MRI. Is it a Cushing's disease or an ectopic Cushing syndrome? Let's have a look at ectopic Cushing syndrome in children. This is from a recent publication by Chanaya in the European Journal of Endocrinology. 161 cases of children with ectopic Cushing syndrome were collected. It is considered to occur in less than 2% of Cushing syndrome in children, compared with 10% in adults, where it is at least 10 times more frequent. This means that for a theoretical test with similar sensitivity and specificity in children and adults, the positive predictive value of the test will be lower than in adults. This is purely mathematical. Usually, morning and UFC are higher than in Cushing disease, but there is a large overlap. The causes are neuroendocrine tumors in 65% of cases and primitive cell-derived tumor in 20%. In the last cause, tumors are usually very large, more than 6 centimeters, and they can be easily seen on imaging. When performing conventional CT scan or MRI with thin slices from neck to pelvis, the tumor will be seen in 92% of cases. This is higher than in adults, where it is around 70%. Functional imaging is less evaluated in children compared to adults. A lack of ACTH and cortisol response in ectopic Cushing syndrome, but also in 20 to 30% of cases of Cushing's disease. As Cushing's disease is at least 20 times more common than ectopic Cushing syndrome in children, a negative test does not confirm ectopic Cushing syndrome and does not rule out Cushing's disease. A negative test would be associated with a 50% probability of Cushing's disease and a 50% probability of ectopic Cushing syndrome. Conversely, a positive cortisol and ACTH response to the CRH or AVP test virtually rules out ectopic Cushing syndrome, with the exception of the rare cases of neuroendocrine tumors that expressed CRH or AVP receptors. The same applies to the high-dose dexamethasone suppression test. If cortisol is suppressed, this is a strong indication of Cushing's disease. If it is not suppressed, Cushing's disease cannot be ruled out. A few pediatric cases of ectopic Cushing syndrome have allowed us to evaluate the performance of inferior petrosal sinus sampling in conjunction with CRH stimulation testing. Sensitivity and specificity are not 100%, but around 95%. Thus, a positive central to peripheral ACTH gradient makes the diagnosis of Cushing's disease highly probable. However, a negative gradient, less than 2 before stimulation or 3 after stimulation, is difficult to conclude, since false negatives have been described in 1 to 2% of Cushing's disease. Since it is an invasive procedure requiring practice and skills, it may not be easily available. The alternative would be to perform a neck-to-pelvis CT scan or MRI, which demonstrated similar performance to IPSS in adults, while the ability of imaging to localize a tumor was higher in children with ectopic Cushing syndrome than in adults. Remember, 92% of ectopic Cushing syndrome could be seen with a neck-to-pelvis CT scan or MRI. So, the next take-home message would be when 8-hour ACTH is over 30 picogram per milliliter and pituitary MRI is negative, remember that the diagnosis for Cushing's disease is the most frequent, around 90%. Perform CRH and/or high-dose dexamethasone suppression test. If positive cortisol and ACTH response to peripheral CRH test, or if suppression of cortisol to high-dose dexamethasone suppression test, the probability of Cushing's disease is 99%. Even if you don't see a pituitary adenoma on pituitary MRI. So you have the choice of a pituitary surgical exploration, or you have the choice of a medical treatment. If negative cortisol and ACTH response to CRH test, or no suppression of cortisol to high-dose dexamethasone suppression test, you have maybe a 50% probability of ectopic Cushing syndrome. So the next step would be the imaging, neck-to-pelvis CT scan or MRI, 92% probability of localizing a tumor responsible for the ectopic Cushing syndrome. And so the last point is the IPPS may be useful only if negative imaging and if performed in a specialized center. What to do in equivocal cases? The last equivocal cases would be 8-hour ACTH level between 5 and 30 and negative pituitary MRI and adrenal CT scan. So is it a Cushing's disease or an adrenal Cushing syndrome? I will go very quickly through this slide. Let's say that an adrenal tumor is usually seen with adrenal CT scan, and that high-dose dexamethasone suppression test will be helpful for diagnosis primary pigmented nodular adrenal disease by showing a paradoxical increase in cortisol. So this is my last slide. As a summary, the Cushing syndrome in children is due to Cushing's disease in 80% of cases, adrenal Cushing syndrome in 20%, and ectopic Cushing's syndrome in 1 to 2%. Urinary free cortisol, overnight dexamethasone suppression test, and 8-hour ACTH measurements are the minimal hormonal parameters for a positive and causal diagnosis of Cushing's syndrome. Depending on 8-hour ACTH levels, pituitary MRI, adrenal CT, or both may be useful. With this measurement in 60 to 70% of cases, you will be enabled to have a causal diagnosis. In equivocal cases, the CRH AVP stimulation test and the high-dose dexamethasone suppression test are useful if they are very highly suggestive of Cushing's disease, meaning that there is a response of cortisol and ACTH to CRH stimulation or cortisol suppressed cortisol to high-dose dexamethasone suppression test. And if the diagnosis is still equivocal after this test, no response to stimulation or suppression, and higher 8-hour ACTH, a neck to pelvis CT scan or MRI, then functional imaging can be useful. I thank you for your attention.
Thank you very much, Dr. Gist. Merci beaucoup. So the question through the chat, and there is a question that comes from Professor Jean-Pierre Chanon, that he asked you to comment, if possible, on the difficulties, the technical difficulties on measuring the ACTH. I mean, the assays difficulties and characteristics, and also because in several places around the world that ACTH measurement is not available or it's difficult to be obtained.
Okay. Yes, ACTH has to be measured. You have to be very careful for ACTH measurements because once the blood has been drawn, you need to put the blood in ice because of circulating protease which may alter the ACTH measurements. So yes, this is true that ACTH measurement is very difficult to perform. For diagnosis Cushing's syndrome, it is necessary to have at least one ACTH measurement, maybe not meet our ACTH measurements may help together with imaging, but well, I'm aware of this difficulty.
And there's a question again from Dr. Guna Shahaf, asking you to be clear about the doses, the exact dose of dexamethasone suppressant. I guess it's related to 1 or 8 milligrams, and if you apply for how many micrograms per kilo in small children?
The corresponding dose is in adults is 2 milligram, and for children it will be 30 microgram per kilogram, 30 microgram per kilogram. So it depends, you know, because you have the high-dose dexamethasone suppression test, which is called the Lidl test. 2 milligram in adults every 6 hours for 2 days, which means 30 microgram per kilogram per dose for children 4 times per day, 2 days. And you also have the overnight high-dose dexamethasone suppression test. The corresponding dose in adult is 8 milligram around 11 or midnight, and the corresponding dose in children would be 120 microgram per kilogram between 11 p.m. and midnight. This is the overnight high-dose dexamethasone suppression test.
So, and the last question from Dr. Mohammed Abdullah, you already addressed this point, but he is asking about age being consider for classifying the etiology of Cushing's? Yeah.
Sorry, I missed the question.
Has the age to be considered in classifying etiology of Cushing's? Yeah. Yes.
Well, it might, but it's difficult because you have overlap. The younger the child is, the higher the probability of adrenal cause is present. The older the child is, the higher the probability of ectopic Cushing's syndrome is. But even if this case, the child is an adolescent, the probability of Cushing's disease is really.
Okay. Excellent. I guess our time is finishing. So thank you very much, Dr. Regis.
Thank you.
So the last speaker of this adrenal symposium in this first GPED annual meeting will be Dr. Richard Aukus. He's very well known for many of you. Dr. Aukus is a professor of translational medicine at the University of Michigan in the US. And he will be talking about the management of patients with congenital adrenal hyperplasia. Please, Dr. Aukus.
Hey, I'm trying to turn my video on. There we go. Okay, great. And I'm going to try to share my screen. Okay, does this look good?
Yes. Perfect.
Okay. So through the miracles of modern technology, I'm glad to be here today and delighted to be able to speak with all of you about some very interesting stuff we've been working on lately. These are my whoops, let me see. There we go. These are my disclosures. And so I'm an adult endocrinologist. And because you pediatric endocrinologists have been doing such a great job of taking care of your children for about 20 years, I now have to inherit them for another 50 to 80 years. And I'm concerned about their long-term health, not because of anything you did, but because of the underlying pathophysiology of the diseases. And so I'm going to talk about congenital adrenal hyperplasia today. And the first thing that I want to let you know is that in 21-hydroxylase deficiency, which is the most common form, 95% or more of all cases of CAH, is that the main androgens are not the ones we've been measuring for the last 50 years, not androstenedione and testosterone, because androstenedione is actually a good substrate for this enzyme CYP11B1, the adrenal. Actually, let me use the laser pointer, make sure it shows up. This enzyme here, which also converts 17-hydroxyprogesterone to 21-deoxycortisol, which is a very specific biomarker for this disease because it only comes from the adrenals. And because androstenedione made in the adrenals gets 11-hydroxylated, this steroid, 11-hydroxyandrostenedione, is actually a better biomarker of the disease. And it gets metabolized to 11-ketotestosterone, which is shown over here. And this is the phantom androgen that we kind of knew existed for a long time, but we couldn't find it. So as an adult endocrinologist, I see many young men who come in with a normal or low testosterone, but suppressed gonadotropins. And this is the androgen that's suppressing their axis. Now, Lawson Wilkins figured this out many years ago. And he surmised that the adrenal in the CAH patient was not able to make cortisol, that's CHO, or aldosterone, that's NA, but was instead making androgens. And these androgens were suppressing the gonadal axis and preventing fertility in both males and females. So a reason that if he gave cortisone therapy, he would provide that negative feedback that the loss of cortisol has caused, suppress the ACTH and therefore suppress the adrenal androgen production and restore gonadal function to allow puberty and fertility in adulthood. Now, that's the treatment that we've been using. And I'm going to give you some concepts about where we are now with that. So hydrocortisone is still the best if you can get it. And I know this is an international conference. In some parts of the world, hydrocortisone comes in 1 milligram tablets. In the US, the smallest is 5 milligrams. In other places, it's a 10 milligram. In other places, it's not available. So what I like to do in the adults is maintain hydrocortisone. It usually has to be given 3 times a day. And that's the problem with this drug. It has poor pharmacokinetics. It only lasts a half-life of about an hour. And so we have to give multiple doses. Now, if I replace someone's cortisol deficiency adequately with that, but their adrenal axis is not, their adrenal androgen production is still high, the next thing to do is to add a bedtime dose of a long-acting glucocorticoid like prednisolone, methylprednisolone, or dexamethasone. And in the United States, we would use dexamethasone and prednisolone as the liquid formulation so that we can very precisely titrate very small doses like 0.1 milligram of dexamethasone or 1 milligram of prednisolone. If that's too complicated, and you can, the analogy would be like type 1 diabetes therapy. This is like adding NPH at bedtime with daytime short-acting insulin. We would do sort of a split mix regimen, which would be prednisolone or methylprednisolone, and I give the replacement dose in the morning, which is 2/3 to 3/4, and then the minimum bedtime dose to control the adrenal androgens. And then dexamethasone I reserve for really bad situations like adrenal rest tumors and things like that. So empirically, if you look at these total daily doses, the daily cortisol production rate is about 7 milligrams per meter squared per day on average. So we really want to be at about 10 to 15 milligrams per day in an adult. So what turns out to be is that the average CH patient is at the high end of this, which means that they're getting about a twice physiologic dose. And so what we've been trying to do is to find a way to lower the glucocorticoid dose, but yet maintain the androgens. Now, currently what we do is we look for Cushingoid features, bruising, striae, skin thinning, and then in the adults, I look for weight loss, anorexia, evening fatigue, the dose distribution by trial and error. And again, with hydrocortisone, you can measure a cortisol value to see if they're getting good exposure. Sometimes concomitant medications will cause rapid clearance of cortisol, and you can test this by measuring a trough value before the second dose. And then mineralocorticoids, I know the pediatric endocrinologists are very good at this, but the adult endocrinologists are not. So I always check standing blood pressure, plasma, renin, and potassium at every visit. So in the men or the post-pubertal children, I want to see their gonadotropins in the normal range and the LH higher than the FSH. And I want to see the androstenedione less than half of the testosterone, because when men are making testosterone from their Leydig cells, they're making very little androstenedione, whereas if they're producing it from their adrenals in CAH, they're making much more androstenedione and even more 11-hydroxyandrostenedione, which we're not measuring. So that's kind of what I like to see. And then I get a semen analysis if I can. And in the women, the androstenedione and testosterone track together. But for fertility, I need to suppress progesterone, which is produced from the adrenals upstream of 17-hydroxyprogesterone. And several groups around the world in London, France, and other places have shown that the key to fertility in the women is a follicular phase progesterone less than about 0.6 nanograms per ml, which is 2 nanomoles per liter, because otherwise it's like being on a progestin-only birth control pill, and they can't conceive under those conditions. So what we have now for the next 50 to 80 years of taking care of these people is what I call the Sophie's choice. You can either try to lower the glucocorticoid with physiologic dosing, and that minimizes the long-term comorbidities, and you can mimic the circadian physiology with good compliance, but their androgens will usually be high, their fertility will be poor, and they're prone to tumor development. Or you can try to normalize the androgens and maintain fertility and prevent tumors. But then there will be the weight gain, the myopathy, the immunosuppression, the bone loss, glucose intolerance, cognitive dysfunction that Cushing's patients get and that you just heard of in the prior talk. So it's kind of like this Far Side cartoon that you have to choose between one of two not very good options. So what can we do to target the pathophysiology of this disease better? Well, there's several points where we can intervene. We can try to improve the pharmacokinetics and delivery of hydrocortisone. We can block the action of corticotropin releasing factor on its receptor or of ACTH on its receptor. We can suppress androgen production or block the androgen receptor. And several of these were tried. The NIH had a study in children where they added an aromatase inhibitor and an anti-androgen, and that study is still ongoing. We're waiting for the final readout from that. But in the meantime, a few other groups have looked at modified hydrocortisone delivery. So this is Debbie Merck's group, which delivered hydrocortisone as an infusion pump. Peter Hindmarsh in London has been doing this for some years, particularly useful in patients with very rapid cortisol clearance. And using basically an insulin pump, you can dial in the cortisol in the early morning hours, achieve a normal peak, gradually bring it down, and compared to immediate release hydrocortisone, you can lower the androstenedione, the ACTH, the 17-OHP, and indeed even the progesterone, which is usually the hardest to control. But this is not practical. And if you notice, the dose of about 17 milligrams per meter squared per day is not really any lower than the upper limit of what we hope to give these children. And what we really want to do is get it down to about 7 milligrams per meter squared per day, which is the physiologic dose. So the second approach is to modify the release. And this is a product that's now approved in Europe called F-MODI. It's Chronocort in the United States and not quite available yet. But what it is small particles. So it has an inert core, the hydrocortisone layer after that, and then various preparations were tried with a sustained release layer followed at the end by an enteric coating. So any number of these granules can be encapsulated into a capsule and either swallowed whole or sprinkled on food and consumed. And it turned out that the one that they went with had no sustained release later, just the enteric coating. So it does not dissolve in the stomach. It waits until it gets into the intestine. So there's a delay. Immediate release hydrocortisone would peak within an hour or two. This drug does not peak for about 5 or 6 hours and then has a flattened peak with a gradual decline. So this covers that early morning hours when the ACTH tends to rise much better than immediate release hydrocortisone. And then a second dose would be given in the morning, a smaller dose to cover the rest of the day. And so in the phase 3 study, there was improved control in the early morning hours compared to immediate release hydrocortisone for both 17-OHP and androstenedione. But the average levels were no different because in the rest of the day, the control was pretty comparable. And the reason for that is that the dose was about 30 milligrams per day, or about 16 to 17 milligrams per meter squared per day. So hydrocortisone works pretty well if you give a lot, all right? So that's the problem. Then in the extension phase study that came after 24 weeks, the investigators were allowed to reduce the dose as clinically indicated. And so they dropped the dose of hydrocortisone to about 20 milligrams per meter squared per day. About 20 milligrams per day. And the 17-OHP gradually went up, but not too bad, only to about 10 nanomoles per liter, which is sort of what you get in a treated non-classic patient. And so the dose gradually came down closer to physiologic over the extension phase. And this is a point I want to make, is that when patients with CAH are in good control, then their adrenals atrophy some and they become easier control. Whereas if I inherit them and they're in poor control, it takes a while of high dose treatment to get their adrenals to shrink before I can drop their dose to something reasonable. Well, what else can we do is instead of using glucocorticoids to provide negative feedback to block the androgen production, what if we just block the androgen production? And there's a very good drug for that now. It's called abiraterone acetate. It's used around the world to treat prostate cancer, which is, of course, androgen dependent. And so we reasoned that if we added abiraterone to patients with 21-hydroxylase deficiency who are overproducing androgens, we would remove all those pathways and lower the testosterone and androstenedione. So the dose used in prostate cancer is about 1 gram a day. And we used 100 and then 250 milligrams per day. And at 250 milligrams per day, this dotted line is the upper limit of normal in adult women for androstenedione. We had profound reductions, and everybody normalized after 6 days of treatment on day 7. And you'll also notice that 48 hours after the last dose, the androgens are still much lower than baseline because this drug is basically an irreversible inhibitor of the enzyme. So you have to make new enzyme to overcome the block. So we met the primary endpoint at 250 milligrams per day, and we saw a parallel reduction in testosterone and urine androgens. You might ask, what happened to the 11-oxyandrogens? And I just told you that those are the most important androgens in these patients. And they also came down. And the 11-hydroxyandrostenedione was the only androgen that didn't quite, the only 19-carbon steroid that didn't quite normalize on day 6 and 7 at 250 milligrams a day. But the active androgen, 11-ketotestosterone, did. So this is actually the hardest androgen to control in these patients. All right, so now, instead of using glucocorticoids, is there something else that we can use to suppress ACTH production? And it's CRF that drives that ACTH production and consequent androgen excess and bone age maturation in children. So what if we attack CRF? So it turns out that in the 90s, several drug companies had programs to develop CRF antagonists based on the phenotype of the CRF receptor knockout mouse, which had a resistance to anxiety and depression. So they were in human trials for the treatment of anxiety and depression. And they did not meet their primary endpoints in those studies, but were quite safe. So what we've done is repurposed these drugs for the treatment of CAH. And our first study was with a compound called NBI 77860. We gave a single dose study at 2 different doses, and we kept the patients in the clinical research unit overnight, held their morning glucocorticoid dose until about 2 o'clock in the afternoon, which is this rapid decline here, and compared to placebo on the 300 or 600 milligram dose given at bedtime at 10 p.m., there was a delay and an attenuation of the rise in both ACTH and consequently 17-OHP in all the participants, particularly during that difficult to control early morning hour. We did not go forward with this drug because of a variety of reasons, but instead 2 other drugs were taken forward, crinecerfont and tildacerfont. And I'm going to show you the phase 2 studies with these agents. This is the adult study with crinecerfont, where again, people were put in the clinical research unit overnight to measure their 24-hour production. And then we treated them for 14 days with 1 of 4 doses of crinecerfont, which is NBI 74788, at either 50 milligrams at bedtime, 100 milligrams at bedtime, 100 milligrams with the evening meal, or 100 milligrams with the morning and evening meal. And then we brought them back and we did overnight sampling on the last dose of treatment to compare the 2. So what we saw was greater than 50% median reductions in ACTH and 17-OHP in all cohorts, and that's shown here. And then we saw clinically meaningful and dose-dependent androstenedione reductions in these groups, up to 64% in the highest dose, the 100 milligram BID, which was taken forward to the phase 3 trial. So to give you an idea of numbers, ACTH going from several hundred picograms per mil down to less than 100, 17-OHP from tens of thousands to a few thousand, and androstenedione where 200 is about the upper limit of normal range, mostly into the normal range in all these patients. There was a pediatric trial that was done. a dose of 50 milligrams was given to these participants, and their glucocorticoid dose was delayed until 10 a.m. And despite that delay of the glucocorticoid dose, the morning rise of ACTH, 17-OHP, and androstenedione was markedly attenuated in the participants who received crinecerfont. In tildacerfont, there was a 2-week study and then a 3-month study. In the 3-month study, ACTH came down quickly and stayed down. 17-OHP gradually came down over time, and androstenedione took the longest to come down of all of them. And again, this is what I was trying to say earlier, is that once you have people in control, they actually get easier to control because of the adrenal atrophy. Well, that all led to the crinecerfont phase 3 trials. And I'm going to show you first the adult trial. We recruited patients who were taking at least 13 milligrams per meter squared per day of hydrocortisone. We then randomized them to crinecerfont or placebo 2-to-1. And we didn't touch their glucocorticoid dose for 4 weeks. And then we looked at what happened to the androstenedione at 4 weeks in a placebo-controlled manner, unlike the phase 2 trials. Then we had a scheduled reduction in their glucocorticoid dose to try to get them really to 8 to 10 milligrams per meter squared per day, but at least 11 milligrams per meter squared per day, which is the average cortisol production plus 2 standard deviations. So 7 to 11 milligrams per meter squared per day. And then the patients on placebo were crossed over at the end of this 24-week study to crinecerfont alone, and then there was an extension phase study. So what we first wanted to do was to look at the percent change from baseline in daily glucocorticoid dose, while the androstenedione was maintained no worse than baseline. And that we said was 120% of baseline to allow for the laboratory fluctuations and the day-to-day fluctuations. But a key secondary endpoint was the change from baseline in the androstenedione at this 4-week period, and the achievement of dose reduction in the less than 11 milligrams per meter squared range. We also looked at 17-hydroxyprogesterone. So we randomized 182 patients, and I think probably some of the people on the call now participated in this trial. This was a Herculean effort that involved almost 50 countries, and we had 60 people on placebo, 122 on crinecerfont. This is the largest interventional study ever done in congenital adrenal hyperplasia. I think one of the first things that you'll notice is that over 95% of the patients completed a very difficult 6-month placebo-controlled study. This is how desperate these people are for a better drug for their condition. So they were about 30 years old. Their average daily dose of hydrocortisone was, as I said, around 33 milligrams per day, which is over 17 milligrams per meter squared per day. They were on a variety of combinations. Their androstenedione was about 3 times normal, and their 17-OHP was about 10 times normal. So hypothesis 1 was that in a placebo-controlled manner, we could prove that crinecerfont lowers androstenedione at week 4. And it did. So the androstenedione came down by about half in the crinecerfont group, but didn't change or rose slightly in the crinecerfont group. Now, during this GC optimization phase, the investigators were supposed to keep the androstenedione lower than baseline. And we did that in the crinecerfont, but you can see that the desire of the investigators and the patients to lower their glucocorticoid dose actually resulted in a profound rise in androstenedione in the placebo arm. So it actually almost went up by 50% in the placebo arm. So just to compare the least squares mean difference in the placebo arm versus the crinecerfont group was, again, about a 50% reduction or more in their androstenedione. Same thing happened with 17-OHP, profound lowering with crinecerfont, maintained below baseline, but it went up by about 50%. in the placebo arm. This is the placebo-adjusted difference at 4 weeks. So I think we nailed that down, that crinecerfont did lower androstenedione while glucocorticoids were maintained constant. But the second hypothesis was that this would allow for glucocorticoid reduction while we maintained that androstenedione level. So that involved the stepwise glucocorticoid reduction. And I will point out that there were 4 or so steps that we could take between 4 and 12 weeks. So that's basically 8 weeks to lower the glucocorticoid dose from supraphysiologic to physiologic. I would never do that in clinical practice. So this was much more rapid. And but despite that, what did we see? We saw that we could maintain the glucocorticoid reduction in the crinecerfont group, but not the placebo group. The difference between the two was about 17% from the baseline dose. But remember, this reduction here is a little artificial because the androstenedione actually went up. We had about 62% of patients who were able to maintain that less than 11 milligrams per meter squared per day through the GC optimization time, whereas that number gradually drifted down in the placebo arm. So that was done in parallel with a very similar pediatric study design. But in this case, what we did is we only allowed the investigators to reduce the glucocorticoid if they felt they could, based on the androstenedione control. So in other words, in the adult trial, the goal was, the priority was to reduce the glucocorticoids, whether the androstenedione was normal or not, but in the but at least lower than baseline. Whereas in the pediatric study, the goal was to normalize the androstenedione and then lower the glucocorticoid if you could. So 174 patients were screened, 103 were randomized, well-matched groups, and again, 95% completion rate, even in a pediatric study. A range of patients, but they were all generally on a maximum dose of glucocorticoid, about 16 to 17 milligrams per meter squared per day of primarily hydrocortisone, mostly in the Tanner 3 to 4 range. Androstenedione about twice normal, 17-OHP about 8 times normal, and elevated testosterone. So what we saw is that the androstenedione came down again about 50%, about 200 nanograms per deciliter in the crinecerfont group, then stayed well down by the end of the study, whereas it actually went up in the placebo group, and the same thing happened with 17-OHP. But despite this reduction in androstenedione, we are actually able to lower the glucocorticoid dose 17%, and 30% of those children were able to get to that 11 milligrams per meter squared per day target 0 in the placebo group. So, so the crinecerfont adult and pediatric studies met their primary endpoint. Crinecerfont is in phase 2B studies. The poor control study did not meet the primary endpoint, but the good control study, the 204 study, is ongoing, and the 205 pediatric study has just started. There is now a drug called atumelnant, which is an MC2R antagonist that blocks the ACTH receptor. That phase 2 trial is underway throughout the world. There is an antibody to ACTH that is in phase 1 trials in Europe, and then the gene therapy trial that was ongoing in the US, unfortunately, has been stopped. There was some signal of results, but not good enough, and they'd reached the maximum dose that they were comfortable doing. So I hope I've given you a whirlwind tour of what's new and what we can hope for the future, and I'll close for questions now.
Okay, thank you very much, Dr. August. We have just a few minutes to questions. One question comes from Dr. Jean-Pierre Chanon, who is very much aware about the availability of resources. And would you suggest to follow up patients in places where, for example, androstenedione is not available, the availability is difficult? Also, comment on the variability of using 17-OHP to monitor the therapy.
Yeah, 17-OHP, at least in adults, is all over the place. And that's why we use androstenedione. And so we think that probably, it may be that 11 keto testosterone is the most stable of all. But I would say that when I'm taking care of patients, their clinical response is the most important. I think this is true in pediatrics. If the kids are growing well, and if their bone age is not advancing, which anybody can get a bone age, they're okay. If they're growing too fast or too slow, something's wrong. So in general, I would say that for the males, you can look at testicular size. For the female, and absence of rest from physical exam or ultrasound, if you have that. In the females, menstrual regularity and how frequently they have to shave and so on. So those are, the clinical parameters that I follow. And, even though I can measure androstenedione and testosterone by mass spec, if I have a woman whose androgens are a little elevated, but they have no acne or hirsutism and their periods are regular and they're not trying to get pregnant, I don't necessarily give them more glucocorticoid because I try to spare them those consequences. So I still think that clinical parameters are the most important things. And the usual things that you're doing now are the most important.
Excellent. You comment on this 11 oxyandrogen, especially 11 ketotestosterone. Are there available commercial available assays or only using LCMS, for example?
Yeah, well, in the United States, most of the reference labs have completely gone over to LCMS anyway. So Esoterics, which is part of LabCorp, offers these analytes. And Quest is unsure about whether they're developing it. Mayo has started to develop them. So I think they're coming on board now. But what I think more importantly, whether you can measure them or not, I want you to be aware that they exist. So they are that mystery androgen that explains, even though you may have the testosterone normalized, the patient is clinically not well. And it's because of these other androgens. Just as a rule of thumb, the ketotestosterone is usually anywhere from 2 to 5 times higher than testosterone and has pretty equivalent biological activity. So if you're measuring, so in the men, if their testosterone is normal, but their androstenedione is low, I know the testosterone is coming from their testes, and I don't have to worry about the 11-oxyandrogens. But if it's the other way around, and I'm saying there's no mystery anymore.
Okay, so Dr. August, there will be more questions, but we don't have time anymore. So thank you very much for your presence. And with
thank you for inviting.
Yeah, and with this, I finished this adrenal session on this first GP annual meeting. Thank you very much. Bye.
Greetings from GPED. The Adrenal Symposium has now been concluded. The next session is a plenary session entitled The Phenotype of Type 1 Diabetes in Sub-Saharan Africa. Please exit this session and move to the plenary session by navigating the virtual event platform site to the left-hand corner of your screen. Thank you very much.
This meeting is being recorded.
As well. There we are. No, we are there. Thank you so much.
I just want to verify that. So, good morning, good day, good evening to everyone still attending this very last session of the day. And I'm so delighted to present this plenary session on the phenotype of type 1 diabetes in sub-Saharan Africa. And to go straight into the matter, I have no conflict of interest and nothing to disclose for this particular talk. And this is going to be the brief outline of the talk we are going to have this evening. But type 1 diabetes is an autoimmune disease. As we know, it is characterized by severe insulin deficiency due to the progressive autoimmune destruction of the pancreatic insulin-secreting beta cells. And we know, at least from the literature in high-income countries, that pancreatic islet autoantibodies, which are just they are just markers of the underlying autoimmune process, and these islet autoantibodies are present in over 90% of youths diagnosed with the disease, especially in white European population. And it's now common knowledge to that type 1 diabetes can also present in adults. And this was demonstrated beautifully by a colleague in the University of Exeter, where he demonstrated that over 50% of individuals with type 1 diabetes from the UK Biobank were actually older adults. And the disease management is quite complex. Given the absence of insulin, insulin has to be given, there has to be that, exogenous administration of insulin. But apart from insulin, there are many other things that are to be factored in the management of type 1 diabetes, such as carbohydrate counting, monitoring the type of insulin used and the different insulin regimen. And as you can imagine, this can be very, very complex in low research settings. And so this brings us to the challenges of type 1 diabetes care in sub-Saharan Africa. And I would start with this very beautiful Lancet commentary, which was published some few years ago by one of our mentors, Dr. Silva Bahendeka from Uganda, where he stated clearly that it is true that the global health agenda now accepts that non-communicable diseases are common in low and middle income countries, including sub-Saharan Africa. But it seems that type 1 diabetes specifically seems to be the forgotten sister of this compendium of non-communicable disease. And if we go back to some of the very important WHO multinational childhood diabetes projects called the Diamond Project, we can see clearly that among the close to 50 or over 50 countries that participated in this project back in the 90s, only 3 countries were from Africa. And so from 20 or 2 decades ago, there's actually a huge gap in terms of the epidemiology of type 1 diabetes in Africa. What do we know about this now? And if we look at the International Diabetes Federation Atlas, which was published just a couple of years ago, we still see that sub-Saharan Africa is not really represented in the data, which may be the reason why we think, at least from the literature, that the incidence of type 1 diabetes in Africa is lowest compared to the other region. And this is so because at least we know that there has been a progressive increase in the number of young people diagnosed with type 1 diabetes in Africa. This is actually a cartoon from figures gotten from the IDF Atlas from 2011 to 2021, demonstrating clearly that the number of prevalent cases and incident cases of type 1 diabetes has been increasing also in Africa. And I've recently just gone back to look at some of the few published studies that have looked at the prevalence and incidence of type 1 diabetes in Africa. And after selecting some really good prospective and retrospective papers, we can see from this meta-analysis that the incidence, the summarized incidence or crude incidence for the disease in Africa stood at 13 per thousand per annum. But of course, this is still really far lower than what we see in other high-income and Western countries. So, but coupled to just the low incidence, at least from the data that we are seeing from Africa, there is a problem with regards to the diagnosis of type 1 diabetes. We know, at least from anecdotal evidence, that the diagnosis of type 1 diabetes in Africa is mostly based on signs and symptoms. I believe, and that many other regions of the world still, base the diagnosis of type 1 diabetes on just clinical signs and symptoms, because it's just recently that many international guidelines are proposing the use of classification biomarkers such as islet autoantibodies and C-peptide for the diagnosis of type 1 diabetes. And this is even confounded yet the more in Africa, because there are other subtypes of diabetes that are predominant, especially among young individuals in the African continent, such as atypical forms of diabetes, such as ketosis-prone diabetes that has, it's well written in the literature. But lean type 2 diabetes, which we now know represents about 40% of new onset cases of type 2 diabetes in many sub-Saharan African countries. And so when clinicians base their diagnosis or the discrimination between type 1 and type 2 diabetes solely on BMI, for example, it can be tricky to make the to distinguish between type 1 and type 2 diabetes. But there are other forms of diabetes, such as malnutrition-related diabetes, that have been reported in the young in other parts of Africa. But we now know that the WHO does not currently accept this as a form of diabetes in much more recent classification. And I've gone back recently to do a survey among diabetes practitioners across the African subcontinent. And while I don't yet have that data, but at least from preliminary analysis, we've seen that there is actually limited access to these classification biomarkers. And so clinics do not have access, or hospitals in sub-Saharan Africa do not have access to C-peptide and islet autoantibodies. And so making the diagnosis of the disease really difficult. But some of our studies, especially from Cameroon, we carried out this preliminary analysis using urinary C-peptide to creatinine ratio, showing that at least with this very simple method, which can be collected easily at outpatient, it can be used to distinguish type 1 diabetes from the other types of diabetes, such as type 2 diabetes, GPED, and ketosis-prone diabetes, which I mentioned a while ago. But apart from that, there are now other innovative techniques that we are trying, such as measuring C-peptide on filter papers or dried blood spot. And so in this study, which I also recently led in Cameroon and in Uganda, we actually demonstrated that fasting and post-meal C-peptide from dried blood spot actually gave a robust assessment of endogenous insulin secretion. And this is important because C-peptide on dried blood spot also is quite stable, and so can be used favorably in settings where the pre-analytical handling of C-peptide can be difficult, especially where we have no access to direct centrifugation of venous samples and optimal preparation of samples for adequate C-peptide measurement. And so these are techniques that we are actually trying to develop, which we believe in the next few years we would be able to deploy across clinics in Africa. We also know at least that it's been over 100 years that insulin was discovered in Canada, but in terms of access, we know it's still really difficult because from studies from different countries in Africa show that insulin was absent at least 50% of the time when most of these studies were conducted. So really, this leads beautifully to the fact that type 1 diabetes mortality in sub-Saharan Africa is still relatively high when you put together these challenges, irrespective of the fact that over the past 2 decades, we have insulin provision schemes such as the Changing Diabetes in Children program or the Life for a Child program, which are actually doing a good job providing insulin and care in many sub-Saharan African countries. irrespective of that, we know that there is still limited access to insulin across the region. In some areas, there is poor diagnosis where some young children are diagnosed with severe malaria when they actually are presenting with the acute form of type 1 diabetes or even meningitis. There is the issue of late diagnosis and just the general lack of awareness and education and support or psychological support still contributing to excess mortality of type 1 diabetes in sub-Saharan Africa. And so there is this abstract which I recently presented in the SPAD meeting in Lisbon, which I think is just a couple of weeks ago, where we looked at a number of cases which have just recently died after some studies we conducted in Cameroon. And we can see that the causes of death were severe hypoglycemia, diabetic ketoacidosis, infections. But I believe what is most important in this slide is the fact that death occurred mostly in those who were diagnosed with severe insulin deficiency. And so these were individuals who actually had extremely low C-peptide levels. And so we believe that C-peptide can be a very important measurement, obviously, for survival. And so many of our patients, which we see in the clinic who are not receiving insulin adequately, are probably surviving because of high residual levels of C-peptide. And this is something which we believe we have to investigate further. So just really to summarize the challenges of type 1 diabetes care in sub-Saharan Africa, I would say that we have the issue of the absence of robust epidemiological data, but also difficulties in making a correct diagnosis and also issues around the poor access to appropriate care and especially access to insulin treatment. And so to talk about the phenotype of the disease in sub-Saharan Africa, I'm going to base this on a study which we recently completed across a number of countries in sub-Saharan Africa. And all started with the issue, is the phenotype of type 1 diabetes different? And this question arose because we know that at least for now, the incidence seems to be lowest in sub-Saharan Africa compared to the other regions of the world. And existing data from some studies conducted in sub-Saharan Africa have revealed low rates of islet autoantibodies and slightly raised C-peptide in some studies, about 2 studies, even in individuals who had long duration clinician diagnosed type 1 diabetes. And so this seemed to suggest that the phenotype can be different. And there are studies from South Africa showing that the peak age of diagnosis of type 1 diabetes occurs over 20 years, almost a decade away from that which we see in high-income countries and especially in European population. Obviously, previous studies were limited by small sample sizes and non-standardized methods for some of the immunological studies. And so we really do not yet know what the true phenotype of the disease is in African population and if the etiology is actually the same, that autoimmune etiology we see in other Western populations. And so in this study, our overall objective was really to determine whether individuals diagnosed with type 1 diabetes in sub-Saharan Africa have diabetes actually of autoimmune etiology as we see elsewhere. And so we actually set up this study called the YODA study for young onset diabetes in sub-Saharan Africa, which was a multicentric study across 4 countries in Africa, involving people with a clinical diagnosis of type 1 diabetes, where diabetes was diagnosed at an age less than 30 years, and they were on insulin treatment. We assessed for islet autoantibodies using GAD-IA2 and ZNT8, and beta cell function using stimulated C-peptide, and type 1 diabetes genetic risk using a 67 SNP type 1 diabetes genetic risk score, which has both HLA and non-HLA risk components to the score. And this score was the score developed by Richard Oram and colleagues in the University of Exeter. And so we have now analyzed our data across 3 countries, Cameroon, Uganda, and South Africa, with a total cohort of 894 participants. And as you can see, the median age at diabetes diagnosis of this cohort is at 15 years with a BMI of 21.7, which are really clinical features consistent with what you would see with young onset type 1 diabetes anywhere else in the world. But when we looked at the islet autoantibody levels, we found that the majority of individuals, over 65% overall, did not have any islet autoantibody. And even when we look at those who were close to diabetes diagnosis, so within 1 year of diabetes duration, the rate of islet autoantibody negativity was still as high as 61.4%, actually indicating that the duration of diabetes may not fully explain the high levels of islet autoantibody negativity. Multiple islet autoantibody levels were quite low, as you can see, with an overall rate of 8.5%, and just 16.7% among those who were close to diabetes, so just within a year of diabetes duration. Individually, when we look at the different islet autoantibodies, we saw that the GAD autoantibody was the most predominant islet autoantibody, and this is really consistent with some other studies that have been reported in East Africa, but also in Southern Africa, showing that IA2 and ZNT8 are extremely low, especially when all three islet autoantibodies have been measured. And so, among those individuals who were islet autoantibody positive specifically, we found that they were all diagnosed in their adolescence at an age 14 years, BMI of 21.2. They were mostly insulin deficient, with the proportion of individuals having insulin deficiency defined by C-peptide less than 200 picomoles per liter at 80%, but also they had high type 1 diabetes genetic risk. And so type 1 diabetes genetic susceptibility was higher in individuals who were islet autoantibody positive from sub-Saharan Africa compared to controls of the similar population. And I believe this is important because it actually shows that if you are islet autoantibody positive, you actually have both clinical and immune and genetic features that are also seen in type 1 diabetes in high-income countries. What about those individuals who were islet autoantibody negative? We found that they were also diagnosed in their adolescence with a BMI of 21.7 kilograms per meter square. They were insulin deficient, but at a lesser degree compared to those individuals who were islet autoantibody positive. But surprisingly, they had a significantly reduced type 1 diabetes genetic risk. And even when we look at overall clinical features across both groups, we found specifically that the age of diabetes diagnosis was not clinically significant. If you look at 15 years versus 14 years, the BMI was the same and the HbA1c was the same across both groups. And so these clinical features do not overtly portray type 2 diabetes or another form of diabetes such as malnutrition-related diabetes that has been described in other sub-Saharan African populations. And when we looked at specific Africans and African-specific type 2 diabetes genetic risk score, we found that among those who were islet autoantibody negative, they were not particularly enriched for type 2 diabetes. So we are saying that this group of individuals who are islet autoantibody negative are young and do not have features of type 2 diabetes, and they also do not have features of type 1 diabetes. When we compared our data with data from the United States of America, which was graciously provided to us by researchers from the Search for Diabetes in the Youth study in the United States of America, we found that as a whole, those who were islet autoantibody positive, especially among those who were less than 20 years old and those who were within just 1 year of diabetes duration to match the Search recruitment criteria, islet autoantibody positivity was lowest in the sub-Saharan African cohort compared to blacks and to whites in the Search cohort. But also the Black individuals in the search cohort also showed a reduced type 1 diabetes genetic susceptibility compared to individuals who were islet auto antibody positive. But it was really interesting to find that islet autoantibody positivity does not really matter if you are from a white ancestry, because if you are antibody negative, you have the same genetic risk as those who are islet autoantibody positive. And so we actually are finding something among Blacks in sub-Saharan Africa, which seems to be different from type 1 diabetes and type 2 diabetes, but also at a lesser degree or lesser proportion in Black individuals in the search study in the United States of America, but not in white individuals. And so one other question which would naturally come up is whether these individuals who are islet autoantibody negative, who seem not to have type 1 diabetes, who seem not to have type 2 diabetes, whether they have monogenic forms of diabetes. And we've now recently completed a preliminary analysis from the Cameroonian cohort where we looked for 57 monogenic diabetes genes, at least those that are now known, among individuals who were C-peptide positive but islet autoantibody negative, and we found just 5 genes, giving an overall detection rate of 8.6% and a prevalence of 2%, which is actually similar to that which has been reported in the United study in the UK, but the BBD study in Sweden, actually just indicating that monogenic diabetes may not be the form of diabetes contributing to this non-autoimmune form of diabetes. And this paper just recently came out when we proceeded to actually switch the treatment of the individual who actually had the HNF1 alpha MODY case in Cameroon. And as you can see, we found no GCK mutation, probably as a result of selection bias, because we had individuals who were young, but also who had very severe forms of diabetes because they were treated with insulin. And so the summary of the findings of this study is that we have actually showed heterogeneity among individuals with apparent type 1 diabetes in sub-Saharan Africa, while there is the classical autoimmune form of diabetes characterized by islet autoantibody positivity, high type 1 diabetes genetic susceptibility, and severe insulin deficiency. The majority of individuals actually seem to present an atypical form of the disease characterized by islet autoantibody negativity, low type 1 diabetes genetic risk, and C-peptide features and clinical features which also do not suggest type 2 diabetes. And this actually indicates that there may be another etiology of this form of subtype of diabetes which we are picking in this sub-Saharan African cohort, which seems to be non-autoimmune. And so the conclusion of this study was that classical autoimmune type 1 diabetes actually does exist in sub-Saharan Africa, and the phenotype seems to be identical to that which has been described in other parts of the world, and especially in high-income countries. But that there is a group of individuals, and that most youths actually who are diagnosed as having clinical type 1 diabetes actually have a non-autoimmune insulin deficient form of the disease, and that at least from our preliminary analysis with the search cohort, that there is evidence that this non-autoimmune etiology diabetes is also found among Blacks in the United States of America. So I'm going to end this presentation by just some perspectives. There is this correspondence which was published just about a year ago, a plan to improve the global type 1 diabetes epidemiology data, and which has now led to this new evolving collaboration called the Diamond 2 Action, which actually seeks to form a framework to build robust epidemiological data for low and middle income countries, and especially in sub-Saharan Africa, where there would be studies looking at the prevalence, the incidence of the disease, but specific studies looking into the clinical aspects of type 1 diabetes in African populations, but also studying the natural evolution of the disease. And while not neglecting aspects such as health systems, indicators, and health outcomes, but also social determinants of health, which are quite important, especially in low and middle income settings. So we believe that this might be an initiative which will build a bedrock to provide further robust data on type 1 diabetes in the coming years. And so I just really want to end by acknowledging colleagues and mentors with whom I've been working for the past 5 to 6 years in order to build evidence on type 1 diabetes in sub-Saharan African populations, and also some of the funders of my current study and other studies that are on the ground, the NIHR and the NIHR Exeter Biomedical Research Center. Thank you very much for listening to me, and I'll hand over to the chair. Thank you.
Thank you very much, Dr. Kati. This is really a very, very interesting lecture. And I think your research program is, it's endless. You probably have quite a few more years to study this. But for me, the important aspect is that it will help providing appropriate care for different individuals based on the underlying cause of their diabetes. And I really think it's a very, very important work. Thank you so much for this lecture. And I wish you a good end of the weekend in Exeter.
Merci beaucoup, Chanel.
Avec plaisir. Avec pleasure.
Merci beaucoup.
There we are. So we are getting actually to the end of this first half day of the first GPED global meeting. And well, I only have two short comments, is that, well, hopefully we will see all of you again tomorrow at 1 p.m. GMT for another exciting half day of lectures and symposia and meet the professor sessions. And the other thing is that this is really our first meeting for GPED, and we would appreciate your feedback, and you will receive, you have seen it on the chat, but you will receive it in your email. We would appreciate you filling in the surveys in order to help us organize the next one. And with that, I will wish you a very good end of weekend, or beginning of weekend, or middle of weekend, wherever you are in the world. And we will see you tomorrow. Thank you very much.